at McMaster University in Hamilton, Canada. So this year, we tried to make the first day a bit varied. We tried to involve hematologists, scientists, radiologists, clinical pharmacists, and we wanted to make sure, that we involve the majority of topics of precision oncology and how it impacts different healthcare specialties. So this is an overview of the 2 days. And of course, we'd like to thank our sponsors, Roche, AstraZeneca, MSD, Amgen, Merck, Kyowa Kirin, and Bayer for continually supporting these educational activities. So without further ado, I'd like to call upon the 2 moderators of the first session. So I'd like to introduce Dr. Marwan Al-Hajeli, who is the head of the Oncology Division and an assistant professor at King Abdulaziz University in Jeddah, Saudi Arabia. Dr. Marwan is an expert in GI and breast oncology. And also I'd like to call upon Dr. Kevin's book, who I introduced, is an associate professor of medical oncology. He's a GI, sarcoma, and cancer genetics expert.
So I'd just like to thank the committee for inviting me to come all the way to Saudi Arabia. It's my first time and it's been absolutely amazing. I'm going to introduce Mohammed Al-Gharni, who is the section head of Division of Cancer Control, Department of Oncology, King Abdulaziz Medical City, and he's going to give us an introduction to precision oncology.
Okay. Assalamu alaikum. Thank you very much, Kevin, for the kind introduction. And it's our pleasure to have you here in Saudi Arabia. So I will be talking about some introduction to the precision oncology and some area that we want to discuss, and that is unique to the precision oncology. So starting with a case presentation, this is a 37-year-old healthy female non-smoker. She presented first to our clinic in August of 2018. Prior to that, she was seen and investigated in a private hospital and for a 9 months history of cough and CT finding of mediastinal lymphadenopathy. She had a PET scan that showed extensive hypermetabolic disease that is involving the chest, multiple lymph nodes, and bone as well. There was also hypermetabolic disease in both ovaries, and she had multiple biopsies in that hospital that showed metastatic carcinoma, and the pathology was reviewed in our hospital, and the picture was consistent of metastatic small cell carcinoma. So we'll come back again to the case during the presentation. So historically, before the beginning of precision medicine, the treatment paradigm was to offer a treatment for certain people with that disease. Some of them, they might respond. Some of them, they might develop the toxicity and the side effect. However, the precision medicine aimed to apply the rule that one size does not fit all, and you try to deliver the therapy that is most tailored to the patient clinical and molecular profile. And this is mainly relevant in oncology because if you look to some of the study, they showed that up to 30 to 49% of patients who have genomic profiling, they have some actionable alteration that can be matched to approved or investigational therapy, which is really something significant. So this is the left side, the tumor pathology. This is what we used to do, and we doing it for many indications. However, we are moving toward the right side, which is the actionable genomic drivers, where you have more of molecular biomarker that led to approval of targeted therapy and immunotherapy. And over the last 2 decades, at least, there has been numerous approval of multiple drugs and multiple agnostic biomarker that you can use the medication regardless of the origin of the tumor. One of the interesting thing about the precision oncology or targeted therapy is the clinically meaningful response that we see with this agent. This is cases of NTRK mutation, and as you can see, with those patients, they have progressed on many lines of therapy. So you have such a remarkable response rate on later line of therapy is something impressive, especially in cancer that is really difficult to treat, like pancreatic cholangiocarcinoma and sarcomas. This is also true for the immunotherapy. All of us aware about the pembrolizumab agnostic indication for MSI high tumor. Even if you look to this study that looked for chemorefractory patient, you can achieve 53% response rate in those heavily pretreated patients, which is something remarkable. The other thing that is also noticed with the modern medication is the durability of response that we see with this agent. So for patients who receive immunotherapy, some of them, if they respond, this response tends to be sustainable compared to the conventional systemic therapy that we used to use. If you look to the frequency of mutation, only few of them that they are commonly detected. However, the rest of these mutations are low prevalence. And this also make a challenge in conducting clinical trials. So nowadays, also the way of looking to clinical trials in the era of precision medicine has also changed. So we moved from the phase 3 randomized study, which we are still doing it, of course. However, with some of these rare mutations, it's not really doable to have phase 3 studies. So the change in the design of clinical trials, so we have now the basket trial, where you can test the effect of one drug on a single actionable driver among different tumor sites. This allows you to enroll even patients with rare tumor type. Also, the umbrella trial design, when you have the one type of cancer and you use a different genetic mutation and you test different drugs. So of course, this allows you to enroll a wide variation of patients with different outcome. So back to our patient. So the final diagnosis is metastatic small cell lung cancer. So we treated her as a histology diagnosis, cisplatin etoposide for 6 cycles. She did not actually show significant response. She had stable disease. Then stable disease actually after 3 cycles. Then she progressed after the 6th cycle. So she was discussed in the tumor board, and the decision was to start immunotherapy on her. She received 4 cycles of immunotherapy. With mixed response. She had developed multiple skin nodules that was very painful. She was treated with radiation therapy, and she showed some response to radiation. At that time, her performance status was 2. The biopsy repeated from one of the lesion, which was the right inguinal region, when we aimed to do molecular profile and to look to review the exact histology, because cell tend usually to respond to platinum, and this patient actually did not respond to the treatment. So the diagnosis came as a neuroendocrine tumor with Ki67 of 30%. We'll come again to the case at the end. So when you look to the actionable genomic alteration that we see in patients with cancer, there are different type of mutation. And with the conventional molecular diagnostic that we have, it has actually limited scope to find all these alteration. And at the same time, as I mentioned, we need to test for these rare and few mutation, which are many. And by all these technique that I have showed, you will not be able to do this. So the solution of this has come to a new era, which is the next generation sequencing and molecular profiling. And the comprehensive genomic profiling, it's a next generation sequencing using single assay and to assess hundreds of genes in one test, that they have relevance as a cancer biomarker that will help in treatment for the patients. So this is the some comparison between the comprehensive genomic profiling and other modalities for genomic test. As you can see here, you will be able to detect all the 4 main classes of genomic alteration. The tumor mutation burden and epicyte status will be also reported. The depth also is in favor of comprehensive genomic profiling. However, the cost still is an issue. So it's not experimental. It's a standard of care for some cancer. For example, the metastatic non-small cell lung cancer, patient with intrahepatic cholangiocarcinoma, it's a standard of care to do molecular profile for those patients, and we are expecting more to come in this regard. As you can see here, this is the NCCN guideline. We recommend to have the broad molecular profiling for the patient. And as you can see also here, how the molecular profile in patients with non-small cell lung cancer has changed the way of managing those patients and how many options they have for treating those patients. Also, the outcome of patients who receive driver with targeted therapy is actually superior to a patient without any targeted therapy. This is also true for patients with biliary tract cancer who are heavily pretreated and they were treated in the subsequent line with targeted therapy. They showed a better survival compared to those without driver mutation. So back to our patient here, comprehensive genomic profiling showed that she has ROS fusion. At that stage, she was ECOG-3 and high dose of morphine. We were planning to refer her for palliative team. However, after the discussion with the patient and her family, we started her in crizotinib in December 2019. And after 3 months of therapy, she showed remarkable response clinically and radiologically. And she was able to return back to her work, and she stopped her analgesia. So we are expecting more and more of tumor agnostic biomarker to come, more biomarker that we need to test. And at the same time, there are growing information that we have. So we have the patient information, we have the imaging that we get from the data, we have the molecular information, the pathological information. So huge information that we are having nowadays that we can collect and trying to personalize the approach for patients. So how we can manage all this information and how we can make the use of this big data and information. So one of the approaches to have the molecular tumor board, where it's a new way of looking to cancer cases and addressing these cases at the molecular level, trying to find the most appropriate therapy for those patients. And as I mentioned, because of the rich amount of information that we need to analyze, the multiple mutation, the mechanism of resistance, sometimes we don't know based on molecular profile whether this is a somatic or germline. So there are many reasons actually to have a molecular tumor board. But also there is a challenging into doing a molecular tumor board, some of them related to the cost of comprehensive genomic profiling. The other thing, which is also a challenging, is the expertise availability. So you need also scientists, genomicists, pathologists, and other experts in the field to try to analyze this information and to approve the drug. And at the same time, access to this medication is not easy. Access to clinical trial sometimes is difficult for our patients. So when we look to the cancer care, actually, although precision oncology mainly focus on treatment, but I think we should also think more of comprehensive care and trying to deliver a personalized care across the cancer care continuum, starting from prevention to treatment, then end-of-life care or survivorship. And one of the things that has evolved for over the last 2 decades is the hereditary cancer predisposition syndrome. And I think it's one of the good lesson for personalized medicine. The information that we get from genetic testing is not only about risk assessment, but it also can help in personalize the risk reduction intervention, and our therapeutic intervention as well. The example of this is BRCA. So starting from over the last 3 decades, from just a cancer gene that increased the risk of cancer, now we have therapeutic implications for patients with BRCA cancer, especially in patients with breast cancer. We are talking nowadays about adjuvant population. So this is really a significant change. I'm not going to spend time on this. About the integration of somatic and germline mutation, but definitely it has a role as well. Also talking about the comprehensive care across the cancer care continuum. First migration is also the concept that is growing, which means that the therapy that is trying to move them earlier for patients and try to optimize in the static setting. And I think all of us know the hormonal therapy for breast cancer that was used in metastatic breast cancer now being used in the adjuvant setting, and in some high-risk patients, you can use this medication to reduce their for cancer, breast cancer risk. And the other approach is the cancer interception, when you, instead of waiting for the cancer to develop, you might detect a certain biomarker before the cancer develops, and you might start to apply some therapeutic and risk reduction intervention earlier to trying to optimize the outcome. However, with all these exciting things, it's also still challenging to apply precision oncology. Multiple factors, including economical factor, regulatory, social, technical issues. One of the things that we need to work on is the education, and I think this is one of the chances that we can, all of us, learn about precision oncology, and trying to also to make everyone taking care of cancer patients about the importance of precision medicine and targeted treatment. Because as you can see here, the role of medical oncologist is important and limited, but if you don't have a good support from the lab and from the pharmacy, it's going to be a challenge for you. So improving, of course, the budding with large international and the National Cancer Center, learning from each other, and try to build some database that can help in enhancing our information about our population, expanding the access and compassionate use program by pharma. Also, something can be helpful in this regard. So back to my patient, she stayed on cabozantinib for 18 months. She had a disease progression, and she was started on lorlatinib, and she's still on the medication. As of now, I saw her 2 weeks ago. She's doing fine, and her PET scan showed further response, and she's still with ECOG 0. So by this, I conclude. Thank you very much.
Thank you, Dr. Muhammad, for the excellent introduction to precision oncology. It's my pleasure to introduce our next speaker, Dr. Badr Al-Ahmari. He's a consultant of stem cell and cellular therapy at King Abdulaziz Medical City, and he will be speaking about the evolving role of cellular therapy in solid malignancies.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Marwan, for the introduction. I would like to thank the organizing committee for organizing such amazing program for the precision oncology, and many thanks for the invitation to such amazing conference. Today, I'll talk about the evolving role of cellular therapy in solid malignancies. As we all know, the checkpoint inhibitor has altered the natural history of some of the cancer that we are treating. However, the use of checkpoint inhibitor heavily dependent on healthy and a good number of T cell within the tumor microenvironments. And alteration in the function of those T cells will lead to the mechanism of resistance for the checkpoint inhibitor. And this is how the checkpoint inhibitor actually failed in some of the cancer that we are treating. The success story of the use of CAR T cell therapy kind of genetically modified T cells in hematological malignancies has revolutionized the use of cell therapy in cancer. Today, I'm going to talk about the success story of CAR T cell in hematological malignancies, and then I will touch base on some of the data that was presented for the use of cellular therapy in general in solid tumors. As we all know, the tumor microenvironment full of multiple types of immune cells, and those immune cells collaborate with each other to control the tumor progression. However, the tumor are smart and can evade the immune system in the many different mechanisms, either by downregulating the MHC's molecules or upregulating some certain molecules such as the PD-1 ligand. T cells play a major role in eradicating the tumor cells. It needs multi-step approach until it exerts its full function. Need to have better recognition of the foreign antigen and better trafficking to the site of the tumor cells, better infiltration to the tumor site, and then recognition of the apparently expressed antigen, and exert its effector function against the tumor. Any defects in any one of those steps of T cell effect on the tumor, that will ultimately alter the effect of the T cells on the tumor itself. However, there's multiple ways to enhance the T cell function, and one of them, as we mentioned, the use of different type of checkpoint inhibitors. What I'm going to talk about today is about the CAR T cell, which is a smart way to make the T cell directly go into the tumor cell, recognize them, and exert its effector function without the need for the use of MHC complex recognition. So CAR T cell is a chimeric antigen receptor T cell, which is our genetically modified T cell, actually designed to recognize specific antigen on the tumor cells. That would result in immediate activation, proliferation of those T cells, and then infiltration to the tumor site and eradication of the tumor. So it's basically a living drug. It consists mainly of two parts, actually, and as you can see in your far left receptor, this is typical receptor for the chimeric antigen receptors, and in your right hand, this is typical and B cell receptors that has an extracellular domain that has the ability to recognize certain antigens such as CD19, and this is the consists of this extracellular domain of the CAR T cell receptor. And the intracellular domain is actually consists of the CD3 that is derived from the TCR or T cell receptor, and the co-stimulating molecule CD28. And this will help actually to direct activation of the T cell upon the engagement of the extracellular domain with the specific targets. This is a simple diagram how to genetically modify those T cells. So we have in your left hand the T cell that has transfected with or transduced with a viral vector that carry the construct, and then this construct will ultimately express the receptor of interest and open infusion to the patient. Those T cells will engage with the tumor cells directly and lead to proliferation, and then exert its effector function and killing of the tumor. And how does this happen? We identify the appropriate patient. We do leukapheresis from the peripheral blood, and then we send those leukapheresis products into the manufacturing facility. And in our situation here in Saudi Arabia, we shouldn't actually approach to the United States or to Europe, where the manufacturing facility is there. And meanwhile, while waiting for the production of the T cells, patient will receive bridging chemotherapy just to keep the tumor under control. We wait for like 3 to 4 weeks until we get the product come back to the institution, and then we do lymphodepletion to the patient to allow expansion of the T cell after the lymphodepletion, and then the T cell will be infused immediately after the lymphodepletion, and then patient will kept under monitoring. So right now, as we are speaking, there are 6 approved CAR T cell products for 12 different indications. It is approved for refractory acute lymphoblastic leukemia. This was the first approval in 2017, and also approved for diffuse large B-cell lymphoma, for follicular lymphoma at different stages. And also we have 2 products that are approved for multiple myeloma. So why CD19 is successful? CD19 because it is a lineage specific, and you can see this CD19 expression only specific to B-cell lineage. So basically all B-cell tumor express CD19, and this make it a very suitable target. It is not really expressed in other normal tissue, and this lead to minimization of the toxicity of the CAR T cell. This is the first study, ELENA study, using the Tacicil for treatment of children and young adults with relapsed refractory B-cell lymphoma. So those patients with who are relapsed refractory, even those who relapse post allogeneic transplant, they have a dismal outcome and very minimal chance of achieving remission with the conventional therapy. However, in this study, the overall response rate at 3 months was 81%. This is something we never saw before with the use of conventional therapy, and that led to the overall survival at 12 months of around 76%, and event-free survival at 12 months of 50%. And this led to the first approval of genetically modified T cell for treatment in cancer in 2017. This table summarized the other 3 different products that is used for treatment of diffuse relapsed refractory diffuse large B-cell lymphoma. We do have the Axicil and the Tacicil available in our institution. However, Lysocil is not available in Saudi Arabia yet. And those 3 trials, the ZUMA-1, Juliet, and Transcend trial, those are the trials that led to the approval of the use of the product for relapsed refractory diffuse large B-cell lymphoma. As you can see here, it's a phase 2 trial, most of them, and enrolling around 100 patients in 2 trials, and around 260 patients, 69 patients treated in the 3rd trial. And you can see the overall response ranging between 50 to 80%. However, the CR rate is consistently similar across the 3 trials of around 50%. And this is an example of one of the survival graph that you see in, let's say, in patients treated with Axicil in the ZUMA trial. And it's compared in Scholar data from Scholar 1, which is historical control data for patients who are relapsed refractory diffuse large B-cell lymphoma within a year after first line of therapy. As you can see here, the median overall survival less than 6 months. However, with data from the ZUMA trial showed the median overall survival is around 31 months. Also, this kind of therapy was moved to the 2nd line of therapy. So patients who fail, who are relapsed refractory diffuse large B-cell lymphoma in first line, or who relapse within a year after the first line of therapy. 3 different randomized trial conducting to the use of cell therapy versus the use of salvage therapy, and followed by autologous transplant, which is our standard of care. And you can see in the graph in your left hand and in the middle, both products, the Axicil and Lysocil, showed significant improvement with the use of CAR T cell. And you can see that, for example, in ZUMA-7 study, the median overall survival median progression-free survival was 8.3 months versus 2 months with the use of standard of care. And this also led to the approval of this product to the 2nd line of therapy for those patients who are highly relapse refractory or who soon relapse after first line of therapy. What about multiple myeloma? We know the patient who are triple class refractory multiple myeloma. Triple class, that means failing all novel therapy of multiple myeloma, including anti-CD20, CD38 monoclonal antibody. They have a median PFS of 4 months, a median overall survival of 1 year. BCMA, which is B cell maturation antigen, is an antigen that is abundantly expressed on the plasma cells and myeloma cells. There are two different constructs, ide-cel and cilta-cel, and presenting here only data for cilta-cel from the CARTITUDE one. And you can see in your left hand, after treatment in this phase 2 study, they treat 113 patients after treatment of CAR T-cell. For those who are highly refractory multiple myeloma, you can see an overall response rate of 97% and a CR rate of 82%. This is something that we never see before, even with our conventional treatment with multiple myeloma. And you can see that the PFS for all patients at 27 months is around 54.9%. And for those who achieve stringent CR, the median PFS was not reached at the last follow-up. However, this treatment does not come without certain and unique toxicity. Whenever you have a new drug, you will have new form of toxicity. This patient usually develop something they call it cytokine release syndrome, due to the intense release of the cytokines after the engagement of the T cell with the tumor cells, and also can lead to neurotoxicity due to the alteration in the blood-brain barrier and endothelial cells, and can lead to different form of presentation, from persistent fever, malaise, hypotension, to the need of mechanical ventilation for respiration, the need of inotropic support and ICU admission, and sometimes can be associated with seizure, and sometimes can be associated with cerebral edema. And this toxicity is variable between different products. Some of the products, they have much lower rate of toxicity, and this is compared to other products, and this is mainly related to the type of construct and the type of the use of co-stimulating molecule in those patients. So when you talk about barrier to CAR T-cell therapy application, of course, there are biological challenges, including antigen escape. Some of the patients who relapse for ALL, who relapse post CAR T-cell, around one third of them to half of them, they actually lost the CD19 expression because antigen escape. Also, the toxicity that is associated with this patient, many patients, they will end up with which we call it on target of target toxicity, which is sometimes they develop a B cell aplasia, because basically you eradicate all the B cell, so they will be at risk of long-term infection and their immunoglobulin replacement. And there are ongoing investigations to enhance the safety of the CAR T cell, and also enhance the efficacy of the CAR T cell for either hematological malignancy or other kind of malignancy in general. There are also manufacturing challenges. As I said, the cells will have to go across the borders. Patient will have to wait for a long time, and it's associated with a high cost, of course. It's need a lot of logistic support. There are also manufacturing delays. And from the data from the ELENA trial, out of 91 patients who were collected, only around 18% of patients did not get their product, and mainly because of either manufacturing failure or patient progression while waiting for their cells, and they die while waiting for the cells to come on the way. With the median time to cell infusion was actually 45 days. So what about solid tumor? So these are some of the challenges that face the application of the CAR T cell in the solid tumor in general. Tumor heterogeneity is one of the major things, because within the tumor itself, it is difficult to find a specific antigen that all the cancer cell express. And also finding appropriate target that is not expressed in the normal tissue is one of the major obstacles when it comes to the solid tumor, because otherwise those T cells will exert its effect on the normal tissue and result in unwanted toxicity. Trafficking of those T cells and infiltrating the site of the tumor also is a challenge. It's not like hematological malignancies. Also, within the tumor itself, the tumor microenvironment, there is a lot of suppressive microenvironment there, either from the molecule that is produced by the tumor itself, or from the available immune cells within the tumor itself that is suppressive and can suppress the T cell, even if it is CAR T cells, such as T regulatory cells that has been shown in hematological malignancy. It can suppress the CAR T cell or the myeloid-derived stem cell, or we call it MSTs. This table summarizes some of the published data about the use of CAR T cell in solid tumor. One of the solid tumor target that are in advanced stage, clinical trial stage now, is the CAR T cell against mesothelin. There is a lot of interest on this target, and there's a lot of development on this target. This data showing the use of this target in metastatic pleural mesothelioma, where they inject actually the CAR T within the pleural space, and out of 25 patients treated, you can see that there are 2 patients achieve complete remission. Also, the use of CAR T HER2 in pancreatic cancer. Also, there's some advancement on that. And we'll talk about later about what are the current targets that are under development in the CAR T cell itself. There are other immune cells, of course. There's not only CAR T cell, tumor infiltrating lymphocytes been there for a long time before the CAR T cell, also T cell receptor T cell as well. And tumor infiltrating lymphocyte isolation is somehow difficult, because you have to have the tumor itself to be excised, and then you have to isolate the T cell from the tumor itself, and then you have to expand them and then infuse them again to the patient. There are multiple differences and similarity between TCR and tumor infiltrating lymphocytes, but the major difference that the TCR is MHC restricted, so not all patients will get benefit from the use of such therapy. And for the TILs, its manufacture complexity is what's make this also difficult. And this is explaining how the TILs are isolated from the tumor from the patient after tumor resection, while the TCR actually isolated with the use of leukapheresis. So I'm showing here the NCI experience with the use of TILs for metastatic melanoma. These are pooled data of 226 patients from different clinical trials, which showed here a CR rate of around 22%, with a median survival for all patients of around 22 months. And you can see here that patient who achieved CR, actually, the overall survival at 10 years is around something above 95%. Also, there is a recent data, I'm sure that you're aware about it, published 2 months ago. It's a Netherlands experience with the use of tumor infiltrating lymphocyte for patients with advanced melanoma, those who failed first line of therapy. 80% of those patients actually failed a checkpoint inhibitor. The patients were randomized between tumor infiltrating lymphocyte versus ipilimumab. And the study met its primary endpoint, showing a progression-free survival of 7 months for patients with the TILs versus 3 months for patients with ipilimumab. You can see the objective response was 49% in patients with the TILs group versus 20% in patients with ipilimumab. Of course, the adverse effect is higher with the TILs because you are using lymphodepleting chemotherapy, high-dose cyclophosphamide. So majority of the adverse event associated with TILs was actually associated with neutropenia, cytopenia, febrile neutropenia, and use of blood products support. With regard to the TCR treatment, I selected here only recently published data for TCR treatment in solid tumor. One of the things that I want to highlight, the synovial sarcoma is one of the solid tumor that are not successfully, I would say there are good responses with use the TCR treatment for those patients. Either use the MAGE, which is the cancer germline antigen, or the NY-ESO-1. There are around the overall response rate for those patients was something between 40 to 50%. And there are few CR, like 2 to 3 patients who achieve CR in different trial for the synovial sarcoma. So in general, we'll talk about there are around 2,700 active cell therapy available now. And you can see that there are many of them are under development in the preclinical phase, but around 500 they are within the clinical phase. The top target for the cell therapy in general are tumor-associated antigen HER2 and mesothelin, and also for the solid tumor that are under treatment for CAR T-cell, the top clinical trial target for cancer are glioma, pancreatic cancer, and lung cancer. And within the clinical trial, the top target for cell therapy is mesothelin, followed by the HER2 and EGFR. Cell therapy is a complex process, so the workflow has been developed, it should be developed, and SOPs are needed to ensure success of interdisciplinary team. The use of multiple stakeholders within the institution has to come together and develop a way. And with the use of TILs, even it's more complex when you connect with the surgeon and the medical oncologist and so on. So everyone has to be ready for such therapy. So in conclusion, cell therapy field is still expanding and evolving. Novel technology using other immune and stromal cell type are being explored, such as NK cells and dendritic cells and monocytes and so on. And a list of targets in the global R&D are expanding. However, there are some challenges, including finding the effective target for solid tumor, manufacturing complexity of this treatment, and also a barrier to clinical application. With that, I conclude, and thank you very much.
Thank you very much, Dr. Badr, for a very exciting talk on CAR T cells and solid tumors. It gives me pleasure now to introduce the next talk, which is going to be presented by Dr. Hana Al-Falih, who is a consultant abdominal imaging specialist, who is going to talk to us on radiological assessment of response in the era of immunotherapy and targeted therapies.
Assalamu alaikum, good evening. I'd like to start with thank you for the great organization and thank you for the invitation to be part of this great event. I'm Hana Al-Falah. I'm a abdominal radiologist in medical imaging department in King Abdulaziz Medical City, Riyadh, Saudi Arabia. I'll be giving a brief talk about the radiological assessment of response in the era of immuno-oncologic and targeted therapies. And these are my objectives. So the tumor response criteria, there has been multiple criteria for variable tumors for just like TROY and NCYG for the CLL and AML. We'll be talking mostly about the solid tumor, which is the majority of the oncology tumor follow-ups. So in 1981, WHO first created the WHO response criteria, and it measured a bidimensional follow-up to uniform the follow-up criteria. And then it had multiple variability among radiologists. So in 2000, RECIST group created a RECIST criteria, which was great for follow-up and uniforming the language among radiologists and for data analysis. The only pitfall is that it was impractical for a busy clinical service with measuring 10 lesions. Lymph nodes were not part of the criteria, and MRI, PET, CT were not included as well in the criteria. So in 2009, they revised the RECIST criteria and developed RECIST 1.1 criteria, which is a unidimensional with maximum diameter, a total of 5 lesions, 2 per organ. Lymph nodes more than 50 millimeter were included in the study, and PET and MRI were included as new lesion in the follow-up studies. However, in the new trial and in the era of immunotherapy, trials and literature shows that patients receiving immunotherapy and targeted therapy showed variable response pattern. And RECIST 1.1 criteria was not great enough to definitely confirm disease progression from the initial scan. And there were some patients who were labeled as disease progression who showed favorable response in the subsequent follow-ups. So they developed an immune-related response criteria, which was a modified criteria from the WHO that was created in 1981. However, the pitfall is that, again, it was impractical with lots of lesions to measure. And in 2013, they tried to combine the IRRC and the RECIST 1.1 criteria, and they developed a good criteria. The only pitfall is that, again, these studies showed that there has some variability among radiologists, and some of these stable disease were mislabeled as progression disease in the follow-up. So finally, in 2017, the RECIST group criteria sat together and came up with the iRECIST criteria, which is currently used in the clinical trials. So this is just a comparison table comparing the immune-related follow-up criteria in radiology, with the IRRC being limited due to large number of lesions to be assessed, and 2 dimension, which increased the variability among radiologists. And the best and most used criteria is the iRECIST criteria, where we have to confirm disease progression in a follow-up study before labeling the patient as disease progression. So why do we need these criteria? We need to create a common language among radiologists and physicians, and for data analysis and research. So we'll just start with a quick review of the RECIST 1.1 criteria, which is used for solid tumors. We usually start with the baseline imaging to be done as close. The baseline imaging has to be as close as possible to the start of therapy. And at baseline study, we identify all malignant lesions. Then we decide which of these lesions are measurable, which include non-lymph node measuring more than 10 millimeter, lymph node more than 15 millimeter, and they have to be reproducible in the follow-up scans. Cutaneous lesion can be included in the RECIST criteria if we have good images with measuring tape. So next, from these malignant measurable lesion, we select our target lesion, a total of 5 lesions, 2 per organ. And lymph nodes are collectively considered as 1 organ. These target lesions are considered representative for the total disease burden. And remember, once a target, always a target. So these target lesions are considered our target for all of the follow-ups in the coming imaging. Then we assess the non-target lesion, which is all other malignant measurable lesions not included as target, plus the non-measurable lesion, including extranodal disease less than 10 millimeter, lymph node 10 to 14 millimeter, and all non-reproducible measurements due to unclear margin of tumor lesion, peritoneal carcinomatosis, or osseous metastasis without soft tissue components. Malignant pleural effusion or ascites are also considered non-measurable. So having said that, now we have a good baseline evaluation for the tumor burden. In the follow-up study, we can calculate the response. We need at least 4-week interval to really assess the disease response. So minimum of 4 weeks, for an average 4 to 8 weeks. Then in the follow-up study, we usually measure the target lesion same as the target lesion from before. And then we visually assess the non-target lesion and assess them qualitatively. Next is search for any new lesions and consolidate all the 3 steps before into an impression. So in the target lesion, we assess the lesion. If they are all resolved, then it's resolved disease. If there's decrease in the burden of tumor more than 30% from the baseline, then it's considered partial response. If the sum of the tumor increased more than 20% from the nadir, which is the nadir is considered the smallest value or measurement from the start of therapy, then it's considered progression of disease. If these, if the measurement or sum of the measurement is not fitting into partial response or progression, then it's considered a stable disease. As for the non-target lesion, we usually assess mainly are they present, resolved, or unequivocally progressed. The non-applicable mainly used if for either imaging technique, non-diagnostic due to lack of IV contrast or poor technique. And we always assess for new lesion, are they present or not? So this is just an example for the nadir. So the nadir is the smallest sum value from the start of therapy, which can be the baseline or any of the prior follow-ups. Here's a suggested template reporting for follow-up for the RECIST criteria. Some institution may use it to help with the standardization. So, however, the RECIST 1.1 criteria is really excellent. However, with the new era of immunotherapy and targeted therapy, we've noticed that there have been an atypical patterns of response seen in many of immunotherapy trials, with initial growth of tumor followed by response. As we know, the most of the approved immunotherapies work on the immune checkpoint inhibitors, and that prevent the tumor cell from attaching to a T cell. So, and having that, we increase the T cell, the activated T cell in the tumor, infiltrating the tumor cell. So, which might give an initial growth of the tumor, but actually, if you look carefully, the tumor cells are not increased. Most of the increase in the growth of the tumor bulk is due to activated T cell. And if you look at the subsequent follow-up, we can see good response and shrinkage of the tumor. So we had to come to a modified RECIST criteria with adding a prefix I. So I RECIST truly begins at disease progression. Until then, until we have disease progression, we can use the RECIST 1.1 criteria because they're similar, they're identical in definition of measurable lesion, target and non-target, selection rules, and response categories with thresholds. So whenever this is a schematic overview of baseline and follow-up assessment. So the baseline for the iRECIST is identical to the RECIST 1.1 criteria, where we assess the measurable and non-measurable lesion. We identify our target lesion and qualitatively assess the non-target lesion. And remember, once a target lesion, always a target lesion. So in the first follow-up after initiation of therapy, we quantitatively assess the target lesion and calculate the sum using a formula. And then we qualitatively or subjectively assess the non-target lesion. And when we assess for new lesion, it's considered as a separate assessment. We never add any new lesion to the sum of the target lesion that was initially selected. So new lesions has to be calculated and mentioned separately. So using iRECIST criteria, if you have a complete remission, partial response, or stable disease, then we follow the same as RECIST 1.1 criteria. However, if we have disease progression, given the nature of immunotherapy, it's considered unconfirmed disease progression. And this is the definition of disease progression. So if we have any new lesion, any increase in the tumor burden in the initial post-therapy follow-up, it's considered unconfirmed disease progression. And how to deal with this unconfirmed disease progression? How can we tell, is it truly disease progression, or is it pseudo-progression related to the activated T cell? Well, having the unconfirmed disease progression permits continued follow-up beyond the initial disease progression if the patient is clinically stable. And we do another follow-up at 4 to 8 weeks, and then reassess these target lesions. If there is any further growth of the tumor, then it's confirmed disease progression, and we need to discuss the patient in multidisciplinary meeting and discuss if we should change or stop the medication, the therapy. If the tumor burden is stable and it's still more than the progression disease level, but did not get worse, then still the patient stays as unconfirmed disease progression. And if he's clinically stable, then we can do another follow-up at 4 to 8 weeks and reevaluate. If the target lesions or the sum of target lesions are stable and below the threshold of progressive disease, then it's considered stable or partial response disease, and we may continue the immunotherapy. If all lesions are resolved, then it's complete remission and good for the patient. So here's an example case for what we've just said. So here we have a patient at baseline examination who had liver and spleen lesion. So we picked target lesion, 2 lesions per organ. In this case, the patient had only liver and spleen lesions. So 2 lesions per organ, and then we calculate the sum, which was 100 ml, 100 millimeter. In the first follow-up after therapy, 4 weeks later, showed interval growth of the tumor burden. So we labeled this patient as disease progression, but giving the therapy of immunotherapy, then we have to add the prefix I and consider him as unconfirmed disease progression and need another follow-up in 4 to 8 weeks interval. Here's the confirmation scan 4 weeks later from the unconfirmed disease progression showing further tumor growth. So having 2 consecutive scans showing further interval growth confirms that this patient is having disease progression and not pseudo-progression. Here's another example. This is the same patient with the sum of the target lesion of 100 millimeter. And then the first follow-up after initiation of therapy showed the disease progression with interval growth of the sum of lesion. Plus, there is a new lesion in the liver measuring 14 millimeters. So he has 2 criteria, label him as disease progression. Giving the patient receiving immunotherapy, we need to make sure that this is true disease progression. So we need another follow-up to confirm that. In the next follow-up, we can see good response and size reduction of the lesion, measuring 60, the sum of the lesion measuring 60. Again, you notice that we only measure the same lesion that we labeled as target lesion in the baseline scan. And all new lesions are documented separately in a separate line. So in this patient, he had good response, meaning that there's partial response and we may continue the therapy. Giving this low or decrease in the value, we reset the bar. So this is considered our nadir, or the smallest sum value for the sum lesions from the beginning of therapy. And we use this bar as a judgment for future follow-up study when we are deciding if there is any progression disease. So in this case, we continued, the patient continued therapy, and he did another follow-up scan, which showed interval increase in the tumor volume or tumor bulk compared to the nadir, which is the second visit. If we look carefully here, we see that the sum of the target lesion is 71 millimeter, which is less than the baseline tumor bulk. But because it was increased compared to the nadir, which is the lowest value, it is considered as disease progression. And because the patient is on immunotherapy, it's considered as unconfirmed disease progression, and we need another follow-up to confirm that and exclude any pseudo-progression. So this is the general rule of follow-up in for patients on immunotherapy. Always, you have to be careful looking for pitfalls and complications in patients who is receiving immunotherapy, which can be as pseudoprogression or hyperprogression. And we should look for the pitfalls of immune-related adverse effect, as the checkpoint inhibitor prevent the tumor cell from attaching to T cell. So we are increasing the activated T cell in the body. So increasing the immune system, which may cause the immune system to attack the normal tissue, not only the tumor cells. So pseudoprogression. Pseudoprogression is a transient increase in tumor burden from baseline, but which is not confirmed as progression on the subsequent radiological assessment. As we can see in the diagram, we can see at the start of the treatment, the tumor volume or the tumor increase in size. However, if you see, most of the increase in growth is blue dots, which is the activated T cell. And if you closely follow the patient, you will see further regression of the tumor volume in the subsequent follow-ups. It is uncommon, mostly seen in melanoma patients, followed by lung cancer, RCC, and bladder cancer. Usually happens in the first week of treatment, but has been reported as late as 12 weeks post-therapy. The theory behind the pseudoprogression is that tumor infiltration by treatment-activated immune cells, which elicits an increase in the tumor volume, including lesions that has not been seen previously. And usually it is related to, it has a favorable prognosis in the subsequent follow-ups. Here's a good example for pseudoprogression, where we can see this patient who had left lung metastatic nodule at baseline. In the first follow-up, we can see that this nodule is almost doubled in size, which would mean we think that it's disease progression. However, using the iRECIST criteria, it's considered unconfirmed, and we need a second confirmation scan 4 weeks later. The patient underwent a confirmation scan 4 weeks later, and the nodule almost disappeared with residual subcentimetric nodule, in keeping with partial response and favoring good response or to the therapy. Here's another example for a patient who's a 66-year-old female, known case of lung cancer on immunotherapy. We can see the pre-treatment scan showing a lymph node. In the first scan post-therapy, we can see there is significant increase in size of the lymph node, and there are evidence of 2 new lymph nodes in the anterior mediastinum. So we would think that this is disease progression, but it's unconfirmed, and we need another confirmation scan to confirm that. In the second scan, we can see significant size reduction of the lymph node and disappearance of the anterior mediastinal lymph nodes, in keeping with partial response and good response to the immunotherapy. Here's that same. So pseudoprogression versus progressive disease. If we see tumor growth in the follow-up, how can we tell is it truly progressive disease or pseudoprogression? It's not very easy by imaging. Usually we rely on the clinical and radiological. If the patient is clinically improving or unchanged, then he might be having a tumor pseudoprogression rather than progressive disease. However, if the tumor growth in imaging and clinically the patient is getting worse with high cancer-related symptoms and functional decline, then probably this is a true progressive disease rather than pseudoprogression. However, we always need to confirm by cross-sectional imaging at 4 weeks interval. And usually the decision to call it progressive or pseudoprogression is not only radiological, it needs radiological, clinical, and molecular imaging. Hyperprogressive or hyperprogressive disease is an acceleration of the tumor growth during immunotherapy and rapid clinical deterioration. Usually, it's defined as doubling of the tumor volume over time based on 2 CT measurements. It is estimated around 9 to 29% in advanced cancers. Unfortunately, we're not really sure about the theory. It's not associated with higher tumor burden at baseline scan or any specific tumor type. And unfortunately, it has an unfavorable prognosis, leading to early death and failure of other alternative immunotherapies. However, it has been associated with older age and worse outcome. Here's an example for hyperprogression where we can see a patient known case of TCC in the right kidney and clear liver at baseline. In the first follow-up, we can see increase in size of the primary TCC in the right kidney and development of 2 new liver lesions. In the subsequent follow-up scan, we can see the primary TCC has increased marginally, but the liver shows extensive increase in the size and number of liver lesions, confirming that this is not just a disease progression, but it is a hyperprogression which has poor prognosis. And finally, complications and immune-related adverse events. We should always be careful and look for these immune-related adverse events as they may mimic disease progression. The autoimmune toxicity and checkpoint inhibitors may result in immune-based attack on the normal tissue. Most common organs to be affected are the skin and thyroid, followed by lung toxicity, colitis, hepatitis, nephritis, hypophysitis, and adrenalitis, myositis. Rarely, cardiac and CNS effects can be seen. So here are some examples. The lung manifestation of lung toxicity most commonly present as bilateral non-specific ground glass opacities, but they may present as lung nodule, mimicking new lung nodules, and we have to be aware of that. Second is sarcoid-like reaction. Sarcoid-like reaction present as new enlarged mediastinal lymph nodes. So you should always think of this entity in patient who has overall response to the treatment and disappearance of the lesion or improvement. However, you see increase or new mediastinal lymph node, then you should consider a sarcoid-like reaction, especially that they do give high uptake on PET-CT. The only way to tell is correlate with the rest of the body tumor response, and sometimes take a biopsy. It will give the golden standard at definite diagnosis. Pancreatitis, if we're doing only molecular imaging and PET-CT, we can see that there is a focal area of avid uptake in the pancreas, which at this point, you're not sure. Is it truly disease progression with a new lesion in the pancreas, or is it autoimmune adverse events? Well, we can always correlate with the cross-sectional imaging. In the CT, it has a very typical appearance of focal pancreatitis in the body of pancreas. And we can confidently say that this is pancreatitis, not disease progression. In the lower images, hypophysitis is just enlargement of the pituitary gland, and it may show uptake. And the patient usually present clinically with symptoms of hypophysitis. Hepatitis and cholangiopathy, again, is one of the immune-related adverse events. We usually see edematous liver, abnormal liver function test, and thickening of the biliary system. Thyroiditis is usually enlargement of the thyroid gland. Eventually, the patient may develop hypothyroidism, and it is we can confidently diagnose it by imaging. Colitis is can be focal, segmental, or diffuse colitis. The patient would present with diarrhea and symptoms of colitis, and radiological diagnosis is easy. So what are the future direction in radiology in the era of immunotherapy? Well, imaging biomarkers could be developed to predict patient at risk of developing immune-related adverse events. There has been initial researches in the field of radiomics-based artificial intelligence, and they are very encouraging, especially one of the researches done by Colin. He was able to identify radiomic features at baseline CT, discriminating patients who subsequently developed immune checkpoint inhibitors-related pneumonitis. So the conclusion of his study was it showed a potential for radiomics to identify reliable predictors for immune-related adverse events and to stratify patients according to risk before therapy initiation. So we can tell which patient is at risk for developing immune-related adverse event and who's not before the initiation of therapy. So in summary, knowledge of immunological therapy is crucial in assessing radiological finding. Pattern of response are very different in immunotherapy compared to chemotherapy. Adverse events vary in onset and may involve many organs. Imaging analysis should be combined with clinical and molecular data to yield a more comprehensive clinical decision support system. Thank you.
I will introduce our next speaker, who is Dr. Alotabi. Dr. Alotabi is from King Saud bin Abdulaziz University for Health Sciences and an assistant professor who's going to talk about turning cold tumors into hot tumors.
Thank you so much. Thank you for the introduction. First, I would like to thank the organizing committee for the invitation, and thank you all for being here today. So today I'm going to talk about turning cold tumors into hot tumor to improve the response to immune checkpoint blockade. First, let's take a moment to go over cancer treatment in general. So we have had the old or documented Egyptian old medicine talking about surgeons removing tumors over 3,000 years old. And we have radiotherapy or radiation starting after the discovery of X-ray. We have chemotherapy, which started after the discovery of, or after the World War I. The first agent was developed after, or as a part of chemical warfare research in Maryland. And then we have the targeted therapy, which is tyrosine kinase inhibitors and monoclonal antibodies. So all these four treatment or major treatment had a great response in improving overall survival in cancer. However, some patients will not be responsive to this kind of treatment. So in 2010, immunotherapy reached a great milestone with the first FDA-approved immune checkpoint inhibitors treating melanoma. And in 2018, we had Dr. Elson and Dr. Hanju, who had received a Nobel Prize by their great work with immune checkpoint blockade. So immunotherapy is different in concept. It does not use external force like radiation beam or surgical blade. Instead, it uses the body natural immune response to recognize tumor. So we have, or we learned over the last years about the T lymphocyte, which is T cells that are able to recognize these or circulate through the body every 14 seconds and are able to recognize tumor antigens. And so a great work of modern medicine or oncology nowadays is the discovery of immune checkpoint blockade, which is, as you see, can block or take off the breaks from the T cells and become or help these T cells to become hyperactive against tumor cells. So the major problem we face today is that actually these in some patients, these T lymphocytes are being excluded from the tumor sites. So in this condition, we will not get a good response of these immune checkpoint blockade in these kind of tumors. So what do I mean by that? In 2006, a group in Paris saw or published something very remarkable. They had a scan or cancer or colon cancer scan, and they looked at it or they did a digital assessment using digital imaging and computer software. And they found that the cells or cancer samples that had a lot of immune therapy or the immune T cells infiltrating into the tumor microenvironment did remarkably well compared to the cancer or the patient did not had these T lymphocytes present through their tumor microenvironment. And so after that, scientists have developed or classified these tumors based on their immunological phenotype. So we have had the first one is the inflamed, or what we call them hot tumor. So these are, when we look at them under the microscope, we can see there's a lot of tumor infiltrating T lymphocyte within the tumor microenvironment. And as you expect, these kind of tumors did remarkably well when they are treated with immune checkpoint blockade. The second type, we have the immune desert tumors, and this kind of tumors did not have T lymphocyte present within them. And this is what we call also immune desert or cold or immune non-inflamed cancer. And as you expect, these kind of cancer did not really do well when they are treated with immune checkpoint blockade. And the last one, we have the immune excluded phenotype. And this type here, as you see, we do not have the tumor infiltrating lymphocyte within them, but we have them located within the tumor microenvironment or through or surrounding the stroma of the tumor cells. So the big questions here is how can, or the big challenging question, how can we turn the T cell non-inflamed cold tumor into a T cell inflamed tumor? As you see here, the right side, we have the T cell non-inflamed cold tumor. And so this is characterized by low inflammatory signatures, absent of intratumoral CD8 T cells. And as a result, we have low response rate to anti-PD-1 blockade. And so if we turn this into hot tumors, we can get, this is the one that we characterize as it's characterized with the presence of chemokines, a presence of CD8 T cell, intratumoral CD8 T cells, and also a good signature of type 1 interference. And these kind of tumors, as I mentioned, do respond better to the immune checkpoint blockade. So how can we turn this into hot tumors? In the literatures, we have different strategies used to turn cold tumor into hot tumors. The first is by promoting or increasing the tumor burden mutations and promoting antigen presentations. We have also a strategy by engaging these antigen presenting cells that are located in the tumor microenvironment. And also, we could play by stimulating and enabling and reprogramming the T cells that are located in the tumor microenvironment. And finally, we can reprogram the whole immune innate compartment that reside in within the tumor microenvironment, in particularly the immune suppressive type, which is the myeloid reverse suppressive cells or the type 2 macrophages. So this is the tumor mutational burden in epithelial cells. This is the common epithelial cancers that usually originated from the lineage of the organs. As you see, and as you know, that these kind of cancer are caused by accumulation of mutation in DNA, which create a new DNA sequences that give rise to a new antigens or new mutations. And so the T lymphocyte here can recognize these new antigens and or the mutations and that actually resulted into cancer and can target them. It's ironic in a sense that every genetic changes in this cancer that resulted in the development of the causation of a cancer are going to end up being the Achilles heels that enable us to attack and target this cancer. So here, and so before we move on, we can see here the first type that has the highest mutation burden is the melanoma, which we know is this melanoma is the highest tumor type that do respond to a checkpoint blockade. In fact, this is the first cancer that did receive the FDA approval with the treatment with ipilimumab. So the question is, how can we increase even more tumor mutation burden and promote antigen presentation? There is several ways to do this. The first is by using radiation or radiotherapy. This kind of treatment is, or most of cancer cells are responsive to this kind of treatment. It can induce apoptosis, necrosis, immunogenic cell death. And so the last one is very critical, important, as it's translocate important protein within the tumor cells into the surface and provide important signal, which we call eat me signal, that can result in increased antigen loading and better antigen presentation. We have also chemotherapy, in particular doxorubicin and cyclophosphamide, which can induce immunogenic cell death. These kind of treatment can also induce massive influx of cytokines and chemokines, which result in a differentiation of dendritic cells and therefore better antigen presentation within the tumor microenvironment. The third approach is by using targeted therapy. We know that there are several driver oncogenes are known to be directly implicated in immune suppressive pathways such as RAS, RAF, and TGF-beta. In the literatures, we know that the BRAF and MEK inhibitors can in fact modify the tumor microenvironment, and so targeting these inhibitor or oncogenes pathway can result in activation of CD8 T cells and recruiting of CD8 T cells into the tumor microenvironment. And lastly, we have the tumor vaccine. So this is still experimental, which is in particularly the one that based on a new antigen. It can result in induce strong CD8 T cells and CD4 T cells. Been tested in the preclinical setting. And so the other arm or other strategy is by actually engaging these antigen presenting cells after they are being getting or we enhance their antigen presentation. So there is a different suggested therapy to engage these antigen presenting cells like macrophages and dendritic cells. We have the STING agonist. This is a major driver of adaptive immune response. It regulates type 1 interferon signaling in the tumor microenvironment, which promote the recruitment of CD8 T cells in the tumor site. We have also two like receptor agonists. This is a good modulators for or promoter for innate and adaptive immune response. An example is the tool-like receptor 9, which can induce the activation and maturation of dendritic cells, and these cells are a good eater for antigen or tumor-associated antigen, and therefore can promote antigen presentation to the T cells. We have also CD40 agonist. This is a member of the TNF receptor superfamily that express on dendritic cells. And upon activation of these receptors, it can trigger antigen presenting cells activation and recruitment of CD8 T cells. The third strategy is by stimulating reprogramming the T cells that located in the tumor microenvironment or surrounding or circulating into the body patient. We have what we call the second generation of a checkpoint inhibitor. So we can use that to improve the T cell priming. So the way this generation work is by two ways. The first is called ipilimumab NF, which aims to enhance the activity or the anti-tumor activity of by increasing the Fc gamma receptor binding and the depletion of Treg, which is an immune suppressor cells. We have also a second method, which is called by ipilimumab pro-body therapeutic. This design to improve the safety by reducing the systematic activity and making the protein cleavable by tumor-selective protease at the tumor site. We have also another way by engaging the T cells in the tumor microenvironment, and this can be done through the CAR T cell or by engineering the T cell receptors. Of course, not all tumors will respond to this kind of treatment. You have to be selective in which one you can administrate. Finally, we have to reprogram, or it's suggested to reprogram the innate immune compartment. As I mentioned earlier, the tumor microenvironment could have or had immune suppressive cells, such as the myeloid reverse suppressor cells. These do thrive in the presence of IDO, and so targeting IDO could reduce the MDSCs and increase the anti-tumor activity. We have macrophages. Macrophages, of course, we have two types. The second type is what we call tumor-associated macrophages, M2. And so this also promote tumor growth by in the presence of colony stimulating factor. So blocking this CSF will promote or reduce the tumor associated macrophages. So this is summarizing the 4 or 3 types and the suggested treatment for each one. We have the immune desert. As I mentioned, these the kind of cells that do not have immune cells either within them or surrounding them. And so in this way, it's the most challenging one. We should aim to target several components of the tumor themselves, using radiotherapy, chemotherapy, targeted therapy, also by targeting antigen-presenting cells by the STING agonist, toll-like receptor agonist, also by the T cell itself by generating the T cell receptors or engineering the T cell receptors. In the presence of immune excluded, so we do have these immune cells surrounding the tumor. However, they cannot invade, and in order to help them get infiltrate into the tumor site, we suggest to use radiotherapy, targeted therapy. Also, cytokines can promote the proliferation and activation of the T cells. And in a condition of T cell infiltration, we have a non-functional T cells. So in this, we have the tumor or the T cells in the tumor microenvironment, but they're not functional. So in this condition, we suggest to promote tumor mutation burden by administrating radiotherapy, targeted therapy, STING agonist as well, or the functional one where we can provide, this is the ideal condition, we can provide the immune checkpoint blockade and also administrate the adaptive cell therapy. So this is ongoing clinical trials for this therapy. We have clinical trials that aim by targeting antigen-presenting cells and tumor cells using radiotherapy and immunotherapy. We have the one that targets the chemotherapy and also the immunotherapy, combination of targeted therapy and immunotherapy, and tumor vaccine is still this under experimental, of course. And we have clinical trials that aims to target the antigen-presenting cells using STING agonist, toll-like receptor 9. We have clinical trials that aim on the T cell themselves using oncological viruses, co-stimulatory receptors. All these promote the T cell part in the tumor microenvironment and help them get recruited to the tumor site. So in conclusion, the aim of the current modern oncology and the big challenge is to extend the benefit of a checkpoint blockade to 2 resistant phenotype. The first is the immune desert, or the one that does not have T lymphocyte within them, and also the immune excluded tumor type. We have a number of options acting on different cell type to turn the cold tumor into hot tumor. This is still also under heavy investigations. Additional strategy also should be investigated further. And finally, the toxicity of the agent needs to be evaluated since combining 2 therapy could be a lethal or very toxic. So managing the dosage, the timing is very important. With that, I would like to thank KSAO, KMARC, and Ministry of National Guard, as well as Ministry of Education, in particular the institutional funding program, as well as I would like to take the chance to thank my international local collaborations and my student and my colleague. Thank you so much.
Thank you, Dr. Faiza, for the excellent presentation. And it's my pleasure to introduce the next speaker, Dr. Hana Al-Sheikh. She's a clinical pharmacogenomics specialist and at work at King Faisal Hospital Research Center in Riyadh. She will be speaking about pharmacogenomics and oncology and the role of the clinical pharmacist in the cycle.
Assalamu alaikum. Thank you so much for having me today. My name is Hana Al-Sheikh. I am pharmacogenomics pharmacy specialist. I work at King Faisal Specialist Hospital and Research Center. I have no conflict of interest to disclose today. And during today's talk, I'm going to be covering basic concepts of pharmacogenomics, and then some examples of PGX application in clinical practice, and then modeling on the impact of PGX on drug responses, and finishing up with some basic science information about the implementation process. So we're living in an interesting time where we are witnessing amazing advances in technology and science that help us promoting for precision medicine and improving patient healthcare overall. Precision medicine is a huge umbrella that covers genetic testing that aims for disease diagnostic purposes, for screening and disease prevention. Genetic therapy is also an amazing aspect in it, and we got an interesting lecture earlier today about that. Pharmacogenomics is the rebel against the traditional dosing and one size fits all, where the old-fashioned dosing using different medications until we get to the right medication at the right dose is not recommended if we have evidence against that by using genetic data. And this is all aiming to improve patients' outcome, improving efficacy, minimizing side effects, and sometimes, and most important of all, saving some lives. Precision medicine in oncology has its own map, where it encompasses disease prevention, disease prognosis, therapy selection, and then dosing selection. We have the germline mutations and somatic mutations, and they are all pertinent in precision medicine oncology. For germline mutations, I would start with that. For now, it can help with disease prevention, where one important example is BRCA gene and its association with ovarian and breast cancer, and screening for that can help detecting it at early stages or preventing it from first place. Therapy selection. For therapy selection, we have PARP inhibitors and then their association with BRCA gene, and it's one of the important tests to do before going ahead and treating patients with that class of medication, and evidence is abundant in that regard. For dosing selection, still under the germline mutations umbrella, we have a lot of gene-drug pairs that are supported by a lot of clinical evidence and guidelines. One of them, say, irinotecan, that doesn't have guideline yet from pharmacogenomics aspect, but the drug labeling shows that dose reduction is important or highly recommended, especially for patients that are carrying 2 copies of the mutant gene or having reduction in UGT1A1 gene. DPYD is another example. I'm going to be modeling with that the coming slides. For somatic mutations, so they serve for disease prognostic purposes, such as varying oncogenic driving mutation genes. We have ALK, AGFR, and then KRAS, and their association with the disease prognosis and lung cancer. For therapy selection, also same mutant genes, they are important to be detected and tested for before selecting targeted immunotherapy. So there's a growing need, obviously, for pharmacogenomics. On average, literature says that there are 3 actionable PGX variants per patients. And then there is a recent study that was published last year in our population that showed similar prevalence of these mutant genes, where about 40% of patients or people in this room probably are walking around with 3 mutant genes that are carrying actionable mutations. If they were to start on a medication associated with one of these genes, then probably knowing the presence of these genetic mutations is pertinent. The FDA labeling, which is a really nice source, I would highly recommend you to go to this table, pharmacogenomics biomarkers. It lists 239 oncology gene-related drug gene pairs. Some of them, they're having recommendations if we were having genetic mutations. Some of them, it's just informative for now because there's not much evidence to support that. This illustration shows still that for the actionable mutations, meaning that if the patient is having that mutation, then probably there is a recommendation for that medication related to that mutation. In oncology, which is the first column on the left, it shows that 75% of these gene-drug pairs are under the oncology umbrella, which is why we're talking about this today in this talk. I summarized here because I was talking about the pharmacogenomics recommendation guidelines. So CPIC, which is the Clinical Pharmacogenomics Implementation Consortium, it aims to collecting and curating the best available evidence for gene-drug pairs. I summarize them here under 4 categories. One of them is oncology, which is the first one. So there are published clinical guidelines linking fluoropyrimidine and DPYD. So if you were to test for DPYD, then probably there's a good recommendation that was reviewed by highly experted professionals in that field. Tamoxifen has its own guideline, thiopurine. Irinotecan guideline is on the way, and then the subsequent gene drug pairs. Pain also is another palliative care class of medications. We have the opioids, NSAIDs, and tricyclic antidepressants. So they do have their own guidelines. Psychiatry, because a lot of patients with cancers, they're probably going to be on an SSRI or TCA, so they also have their own guideline. The grade couple or gene drug pairs, they don't have guideline yet, but probably there's a recommendation in their drug labeling. Supportive care, we have the PPIs, ondansetron, voriconazole, allopurinol, they all have well-established guidelines. So this is nice that we know the evidence, we know the need, but how we'd like to see that pharmacogenomics implementation in our practice. Ideally, the story begins with identifying the patient. Your patient might have heard about the genetic testing, said, hey, I want to do this genetic testing, or you as a provider are interested in doing that genetic testing for your patient. So it can be preemptive. Preemptive meaning this patient was not started on medication yet, and there's no plan to do it for now, but we want to do that genetic testing and keep it on profile, like CBC or any other other testing, and keep it for future. This is ideal. We'd love to see that, but the problem is it could be cost-associated reasons, logistics. We don't have that testing in our lab. We have high volume of patients, and then the lab cannot accommodate that. So the other option would be reactive. So your patient is planned to start on a medication that can be impacted by genetic testing, such as capecitabine. Maybe this patient develops side effects, and now we want to know why they developed that. Kind of too late, but we are curious, so this is another way. Or patient failed multiple lines of therapy, and we want to know what's going on so we can narrow the options and start with the right medication. Now the doctor places the order in the system, and then patient goes to the lab. They can give a sample that can be saliva, can be blood, or can be buccal swab. And then the testing menu varies according to the institution. It could be single genetic testing. It can be a panel or sequencing, which is awesome, but also it carries its own package because it's kind of expensive, takes longer time, and requires a lot of experience. Turnaround time, big question. It can take 1 to 2 weeks. This is ideal, but sometimes we don't see that in practice, especially if we are sending out the genetic sample to outside lab, if not international or overseas. And then once we get the genetic testing, it's reflected in the chart as genotype, and then phenotype, and then recommendations. I've seen that, and I don't really like it when we have the genetic testing shown as PDF attachment. So it is lost in the file, and so probably the providers after you will not be able to find that, and they will end up with ordering another genetic testing, or worse than that, they don't know and just keep treating the patient without knowing the genetic testing is there. So if we have it in discrete format, like the first time here, so this way it can facilitate doing something fancy in our AMR or electronic medical record, which is the CDS alerts. Not all doctors liking them, but I think they are pertinent here when we design the tool to shoot our pop-up for the provider when they have a critical genetic test result, mutation is present, and they want to start a medication. Consult note is another way to explain, have full medication history, and then explaining all the genetic test results and then recommendations. So it's permanently saved in the chart. This nice looking report, one way of the educational tools that we give to the patients, have all the information about the genetic testing and then what to do with their current and then future medications if indicated. So this looks beautiful, ideal, but there's much more work behind that that happens. So I'm going to speak based on my experience and some things that I've witnessed during my training. So sometimes the order or the decision comes from higher administration. We want to do genetic testing. Everyone wants to do it, but then 5-10 years, it doesn't happen. We don't know why, because it lacks the science in it, which is the implementation science. If we would look at different implementation science papers, they agree on forming the team, which is the stakeholders, reviewing the evidence, and then the tool, which is genetic testing in our case here. And then what are we going to do with the genetic data? And then this is subspecialized because we are talking about genetic testing. We're going to talk about the decision supporting tool and then education to ensure that everyone is aware and using it properly. So I'm going to start with this example to walk throughout that series. Say capecitabine, which is a nice one here. The FDA label until last year used to have, I'm going to read that from here, withhold or permanently discontinue Xeloda in patients with acute early onset of severe toxic side effects. They're probably going to have DPD deficiency. That's it. So we know there's correlation, but still, the recommendation is light and vague. It doesn't say any action. But December last year, it was changed, and that was great news. So it says, consider still softer language, but better than nothing. Consider doing the genetic testing prior to starting Xeloda, and this can be expanded to 5FU. So say that stakeholders heard about that, they want to do it, then what are we going to do now? We need to form a team. So it's an interdisciplinary effort. We need to ensure the stakeholders buy-in. We need to have, now we're in the era of budgeting and making sure where are these resources allocated. We need to have good business plans showing that there is a nice or good return of investment. So the team consists of physicians, and most of the papers they're saying that physicians are the champions for implementation. So if we would start with a passionate champion or physician who's really caring about doing that genetic testing, then probably this implementation will work. Having the lab engagement is really important, especially if you are wanting to do in-house testing. So in-house testing is something I think we're able to do here in different institutions. We have the capacity and personnel. And then informatics team, because we need to put this data from the machine into the Cerner or EPIC, the electronic health record. And then patients, they're also stakeholders here, educating them and making them aware, and consenting to do the test is a key. Otherwise, it will not happen. And then your PGX pharmacists and other pharmacists. So the second part in this cycle, the evidence, we need to know what are the evidence resources that we were looking for. So we have the clinical guidelines, either related to the disease or the pharmacogenomics related guidelines, the FDA label big thing, as I mentioned. And when we select the resource that we wanted to do, then we're going to select which gene drug pair. So now we're convinced we want to have Xeloda, but do you want a Xeloda and 5FU and TPMT plus azathioprine, or just one at a time? So for now, we're going to select one gene drug pair to make it easy. And after selecting that gene drug pair, because it has higher level of evidence, what are the variants that we're testing for? Say that we're not doing sequencing, we're going to have one gene and then certain variants. So we want to see which variants that are having high level of evidence, so we can include them to reduce the work on the lab and then the cost associated with having reagents for each variant. Okay, so there are some questions that I encountered personally, or I went through in literature when I was doing my own reading. Some providers, they will be a little bit hesitant. Sorry, I didn't realize I was squeezing the button. Yes, about the clinical relevance. So what is your threshold for doing that implementation? We want to have a highly impactful gene drug pair interaction. So here we're talking about severe toxicity and maybe fatal cases. So having Xeloda tested for in institution is relevant here, because we want to capture intermediate and poor metabolizers, or patients having intermediate, minimal or no effect activity of DPYD gene. And then the next question, what could happen if we did not do the test? It doesn't really matter. Is it going to impact our patients? So there are a lot of studies saying, yes, grade 3 side effects are more associated with patients who will be started on DPYD blindly. And then if we test them after they got the side effects, big chunk of them, they have reduced efficacy, reduced DPYD activity. So we know that when they are compared to wild type. But also here, I thought this was really interesting because we're talking about mortality. About 10% of patients carrying STAR2A. So this is one of the variants that have absolutely no effect, no activity. If the patient is having one copy, this is intermediate metabolizer. If they're having two, then they're poor metabolizers. And 5FU and capecitabine are absolutely contraindicated. So 10% of these patients will decease or they decease shortly after starting the treatment due to side effects. But when we look, last time I checked, NCCN guideline and version of 2022 in colon cancer, The recommendation still, they're not inclining toward recommending that test because, and copying this statement, the prevalence of this mutations is 1 to 2%. So this is very low, and this is understandable. Why would we test thousands of patients to detect 2%? Despite that, this is really pertinent because we're talking about lives. But actually, what that number comes from, or where does it come from? It comes from one single variant, the STAR2A, that they took that prevalence from it. But then if you're going to sum up the 10 or 20 variants across different ethnic groups, then the carriers of one copy of at least of these reduced functioning gene, it's going to go up to 9%. So we're talking about 9%, a little bit higher. And that comes from mostly studies conducted in patients with European ethnic groups or whites, but we don't know much about DPYD distribution here in our patients. Another important question is, if I do the test, is this going to delay starting the chemo for my patients? So I'm copying this from Indiana University. They have their own oncology practice model. So every patient, their practice model is referred to the clinic. They do the tumor biopsy, and then they screen for somatic and germline mutations, and then they do the pre-tumor board and tumor board, and then doing the action or the decision. So having the test here until the time where the patient is going to be have the decision on the treatment, probably is not going to interfere with that, especially if we have test in-house. The other question, which I think it's important, and it's a good argument when physicians will be a little bit hesitant. What if I started with lower dose, but my goal is cure? So this is the ultimate reason why I want to start the patient. I don't want to risk having patients on suboptimal dose. So this study did compare patients who received reduced dose because of their carrier status and the mutation. So to the patients who are wild type and then receive the full dose. There was no significant difference between patients with a reduced dose compared to the patients who got the full dose. So they're pretty much equal in the overall survival and progression-free survival, which is a good news. It's a small study, true, but there are 2 coming studies. They're recruiting right now, and they're focusing on the efficacy on larger scale. So I'm personally excited to see that study. And then cost effectiveness. So this is another question, doing the tests for all the patients for, say, 1,000 to get 9% of the patients for having the mutation. So these couple old studies that they did compare doing the test versus the traditional dosing, not doing it. And then they did break even. And in the other study, they actually saved some money on doing the test for their patients. But if you notice, these studies are a little bit old. And we know now that the pharmacogenomic testing prices or costs is getting lower because there is a competition between companies. So probably the numbers will improve if we would do another efficacy or cost effectiveness analysis. Okay, so that was for evidence. I spent a lot of time on it because these are actual discussions are going to come over the first few meetings that we're going to have when we want to implement genetic testing. But then the next question, okay, we're going to do the lab test in-house. What are we going to do? Are we going to do it in-house or send out? Do we want to do single gene, a panel, or doing sequencing? And then the turnaround time. So all these are good points to discuss with your lab. And then the other thing is, I mentioned that a little bit earlier. So if we're not doing sequencing, we're going to focus on certain variants of that gene. So looking up the distribution of these variants among different ethnic groups and knowing which are the popular ones in our population, maybe we're going to make us focus on the variants that are pertinent to include in the test. And then what are we going to do with the data? I don't know if you got the chance to look at the JSON files or the return from lab file. They're so complex and huge. So translating these data would require good bioinformatician and lab personnel, and then helping them and encouraging them to have them as discrete data in the file, as I mentioned, so they don't end up as PDF. And then the clinical decision support tools, such as the CDS alerts, they will not fire until we have these data entered as numbers rather than having PDF reports. Education is very important here because we are educating the team who's implementing, and then we are educating the institution, wide institution level activities on continuous basis to remind everyone that the test is available, reminding educating the trainees, and then the patients, of course. Back to the cycle. So collecting all these aspects together would require someone behind to help engaging everyone and keeping them all on the same page, keep track of the progress. So that's basically what I'm doing, and I'm really enjoying doing that because I work with multidisciplinary team. I have dynamic role where I educate patients, engage stakeholders, maintaining and growing implementation across the health. It was a wonderful team, all in order to having that genetic testing up and running in the institution. And then beside that, of course, interpreting the recommended genetic test result and providing recommendations for my patients. So with that, I covered the implementation science very quickly here, but I'm stressing on that because one paper described that it takes the institution up to 13 years to implement or make a change. However, with implementation science, knowing what we're going to do, focusing on the goal, and then making a plan that is applicable, this will shorten that to less than 5 years. So this is the message I want to leave with you before you go today, that implementation of PGX is a multidisciplinary team. The pharmacist serves as an advocate for the implementation and facilitate the uptake. And then implementation science is helpful. I encourage you to do it. And then periodic education, assessment, doing all these key performer indicators to make sure what is going right, and then we're going to keep it, what is going not right, and then work on it and improve it, all in order to have it up and running without failing and then stopping the project. Thank you so much for your time.
So thank you very much, Dr. Hannah, for your excellent talk. And I'd like to thank all the speakers and moderators. And I think for the sake of time, so everyone can have a break, there are coffee and refreshments in the back, and there are pharma. Feel free to approach, any of the speakers if you have any imminent questions. I know I have one for Badr, but we can probably be back in about 15 minutes or so. So at 3:45 to start session 2. Thank you all for listening.
Other side. Other side. You don't have to do it on your right.
No.
No.
Test.
molecular
Thank you so
Thank you
much.
so much.
Yes.
An important test.
Testing. Test.
Okay, so because of this technical challenge, we will a little bit change the schedule, and we will go ahead to the third presentation of this activity, which is universal germline genetic testing for cancer patients, for whom This will be presented by Dr. Kevin Bock. He's been already presented, but he's Associate Professor in Medical Oncology and Durodnitsky Cancer Center, McMaster University, Ontario, Canada. I've heard he was a mentor of two of our colleagues, Kanaan and Mohammed. We're highly privileged to have you with us.
So thank you again for the invitation to come give this talk. I'm extremely grateful. And I'm going to talk about universal germline genetic testing for cancer patients. For whom? So I have no disclosures. There are no drugs that would be directly affected by my talk about genetics. I'm going to talk a little bit about introduction and definitions. The main body of the talk is going to be criteria for universal germline genetic testing. I do want to touch upon the implications of tumor testing and their effect on the germline, and then conclusions. And so I think we have to remember that all cancer is genetic. And so we've got on the order of 10 to 27 nucleotides. And in the lifetime, it's actually quite incredible that we don't all develop numerous cancers. So the boundaries between us having multiple cancers and never developing a cancer is really more philosophical than anything else. It's incredible we don't all end up with multiple malignancies. So what we're talking about, though, the most of the times in this talk today, it's going to be germline, which is mutations that are present in egg or sperm or de novo formation of an embryo. So they are heritable, so passed on from one generation to the next. The majority of mutations that we talk about are in fact not germline, right? They're somatic mutations that only occur in the tissue and therefore are not heritable. So the talk today is really going to focus on germline mutations. And when we talk about universal testing, this does not imply that it's reflexive. So reflexive testing is testing that would occur automatically as part of a standardized protocol. And if we think about in metastatic colon, in the somatic setting, RAS testing, for example, or BRAF testing, most times this is not reflexive, with the exception of IHC for the mismatch repair genes. So traditionally, as you guys all know, genetic testing has occurred through a cancer genetics program model, where usually a genetic counselor is involved, and they discuss the risk, benefits, and alternatives to genetic testing. The patient consents to go ahead with testing. So it's a very involved process. As we expand out to do more universal testing, the whole idea of using a form of mainstreaming really has become critical to this process. And so for those of you who are not aware, mainstreaming is a process where the genetic testing that is germline here is actually ordered by the treating oncologist. So more often than not, it's been the medical oncologist, but more often now we're seeing, for example, breast surgeons who are ordering mainstreaming, and sometimes even radiation oncologists. And it is occurring usually in an appointment that's being there for routine care, whether that's at the original appointment for new consultation or at follow-up. And then most often there is a system in place so that pathogenic variants are flagged by genetic counselors. So at our center, for example, our genetic counselors actually review all mainstreaming results, and they'll send out letters to the ones that are negative, and the ones that are positive, they'll bring in and actually have a further discussion with them. And there are studies actually that show that using mainstreaming increases uptake, and it actually provides for a quicker turnaround time, because you don't have that time for the patient to wait to meet with either the genetic counselor or a cancer geneticist. So back to the question of universal germline testing for whom. Historically in cancer genetic, we've often used a rule of thumb that we would consider germline genetic testing if the pretest probability of finding a pathogenic variant is 10% or greater. And I'll just pause now. You'll see me use the term pathogenic variant, and that has replaced pathogenic mutation. So the terminology is now pathogenic variant generally, but it means the same thing as what you would have previously referred to as a pathogenic mutation. However, we now have these cancer panels that came about Because of massive parallel processing, these tumor panels are very easy. They become a lot cheaper at this point. And so because of that, we can often run 20, 50, 100 germline tests if we wish. And so this, combined with the fact that many of these pathogenic variants are actionable, and whether actionable means that there's going to be heightened screening, or there's going to be chemoprevention or preventative surgery, or what we talk about more here are actionable in the sense of identifying drugs that are targeted. Because of that, criteria have been relaxed. And so where I work in Ontario, we use an approximate 5% pretest probability now as a threshold at which we will often offer testing. I think it's important to realize that we obviously don't have large randomized studies in the germline cancer genetics world, so that most of the guidelines we have are really based on expert consensus. So I just want to show you guys Ontario. Ontario is in the middle in the kind of yellow color. This province is the most populous in Canada. Population is about 15 million people. So that's greater than a third of the Canadian population. And so a lot of guidelines that are developed in Ontario end up being, adopted in other parts of the country. And so I'm going to use as my guideline here the Ontario Health Cancer Care Ontario guideline that was just released back in October of last year on who would be eligible for cancer genetic testing. And because my topic was universal screening, I'm not going to include any criteria that are based on family history, because really what we're looking for here is a patient comes into clinic and based purely on their presentation, so their cancer and their age, would they be eligible for genetic testing? So obviously there are many more criteria that would involve family history, but we're going to exclude those for the purpose of this talk. So probably the most straightforward, easiest one that we all know about is testing for microsatellite instability. So in Ontario, we would test all patients with colorectal cancer or endometrial cancer, irrespective of age or stage. And this is because it's obviously a very important prognostic and predictive factor. So we know stage for stage, patients who have MSI high tumors have a better prognosis. And we also know that there's predictive value in that single agent capecitabine or 5-FU is ineffective in the adjuvant setting, and that obviously immunotherapy has been incredibly transformative, at least in advanced disease. But remember that the majority of cases of MSI are actually not Lynch syndrome, right? So they're not due to germline mutations. They're usually somatic events. Historically, these were mainly hypermethylation of the MLH1 gene, but we now know that there are somatic mutations in the other genes as well. And so because all centers are going to be doing a lot of MSI, you need a way to determine who requires germline testing. You do not want to be doing it on every single patient who has an MSI positive test result. So this is the one that we use in Ontario. And so you see at the top, if they're IHC intact or microsatellite stable, it's very unlikely they have Lynch syndrome. We don't usually need to do any additional testing. The only time that we would do additional testing is if their family history was very, very suspicious, and in which case we would still do germline testing, but it's a very good screening test. The most frequent abnormal test we'll find is MLH1 deficiency, and that's usually due to hypermethylation of MLH1. So you can test for that either through BRAF mutations. So the vast majority of cases that are BRAF mutated, like 99% of them, are going to be somatic and not germline. So a very good test to exclude Lynch syndrome. It's not 100%. I actually saw one case that was BRAF mutated that was Lynch syndrome, but they had a very classic family history. So you just looked at the family. They actually met those Amsterdam criteria, which were very, very enriched. But if you have hypermethylation or a BRAF mutation, we usually stop. That's usually not Lynch syndrome. And then if they have MSH6, PMS2 usually, or MSH2 mutations, we're going to run the Lynch panel. If we find a mutation that confirms they have Lynch syndrome, if we don't find a mutation, we send tumor for somatic testing, and we kind of rule in that it's a somatic event. Where we're a little stuck is if we do germline, it's negative, and then we don't find somatic mutations. I think we don't exactly know what those patients are. So you need some kind of algorithm like this when you do MSI, or else you're just going to be inundated with germline testing. So all patients with pancreatic adenocarcinoma should be screened irrespective of stage and age. And I think I had talked to Mohammed, and this is what they're doing. And we're doing that through a mainstreaming process because it would quickly overwhelm our genetics program, even just with pancreases. And this is because there's actually been several studies that show a greater than 10% PV selection pickup rate in unselected patients. And in fact, the Mayo Clinic found a pickup rate of 15%. So really quite low hanging fruit. And the majority of them are in homologous repair pathways where it actually might have implications for treatment as well, in that platinum agents might be more effective, and then the possibility of PARP inhibitors as well. So what about hereditary breast and ovarian cancer? So this is one that's actually heavily dependent on family history, but I'm excluding all of those criteria. So if we actually start from the bottom and work our way up, the easiest one is all patients who have invasive epithelial ovarian cancer. And that would be another criteria that we would do mainstreaming. The one caveat here is that patients who have mucinous, clear cell, or endometrioids should be screened for Lynch syndrome or MSI as well. We offer testing to all male breast cancers and all triple negative breast cancers under the age of 60. And then we have somewhat arbitrary rules about individuals with a personal history of breast cancer under the age of 45. That was the cutoff in our database at which the 5% pickup rate was the threshold, and then less than 50 with a previous breast cancer. What about prostate? This is another low-hanging fruit that's usually mainstreamed now. So any male with metastatic prostate cancer would be eligible for testing. And then any individuals who have a personal history of high-risk cancer, usually defined as T3 or higher, high Gleason score, lymph node positive, or presenting with a high PSA. And once again, that's 5% plus and has big implications for potential therapeutics because these are often, once again, related to homologous repair deficiencies, and PARP inhibitors might be an option. How about gastric cancer? So this is largely trying to detect families that have hereditary diffuse gastric cancer. So gastric cancer under the age of 50, individuals with diffuse gastric cancer who actually have a history of cleft lip and palate, their likelihood of having an ECAT heron mutation is quite a bit higher, 2 to 3 times those without. So if you remember one thing about diffuse gastric, if you see somebody with gastric cancer and cleft lip and palate, think about genetic testing for them. So hereditary diffuse gastric cancer has lobular breast cancer as one of its components. So if an individual has both of those cancers under the age of 70, they would be eligible for testing, or a woman with bilateral lobular breast cancer under the age of 70. And then these in situ lesions like signet ring cell, in situ or pagetoid spread of signet ring cells under the age of 50, actually quite sensitive for a possible ECAT heron mutation. And these are important to recognize because family members who have ECAT heron mutations, they have a very, very high risk of developing gastric cancer. And we recommend actually prophylactic gastrectomy for carriers. So you want to be able to identify these individuals. So what about renal cell carcinoma? So not surprisingly, individuals who have bilateral or multifocal disease. Remember, because these are germline mutations, this is often a feature of any of these hereditary syndromes, multifocality or bilaterality in paired organs, diagnosis under the age of 45, and then non-clear cell histologies, things like papillary, chromophobe, oncocytic, hybrid tumors, because these are often associated with the syndromes that we see renal cell in. So things like von Hippel-Lindau, tubular sclerosis, something called hereditary leiomyoma, renal cell carcinoma, that actually has a very unique histology where an astute pathologist will actually see that they've got type 2 papillary cancers or collecting duct cancers, which are very suspicious for this syndrome. And then Birt-Hogg-Dubé, where we often see like oncocytic variants. So some syndromic presentations where you really have to know a little bit about the syndromes. So if you saw somebody with kidney cancer and seizures, you would start to think about TS. If they had a pneumothorax, you would think about Birt-Hogg-Dubé. And then hemangioblastomas, where we think about VHL, leiomyomas in FH mutations, and angiomyolipomas. So I will say some of this is getting pretty deep into the minutia of cancer genetics. And so if you go to the Cancer Care Ontario website, there's actually a cheat sheet on there that has all of these criteria, and you could keep it in your clinic and look at it. So what about pheochromocytomas and paragangliomas? And when we use those two terms, for me, it's somewhat semantic. They're the same tissue of origin. I think of pheos as located in the adrenal gland myself, and anything outside of the adrenal gland is a paraganglioma. In the slide that I've shown you, they look at it slightly different, with adrenal gland being pheos, extraadrenal phenos, and then head and neck lesions, paragangliomas. But it's all really the same, and it's just semantics. Irrespective, there's a very high yield. And so anybody with a pheo or paraganglioma, and you know, we will all see pheos at some point, right? A lot of these have not been referred for genetic testing. And up to 35% pickup rate in non-syndromic. So not in a family that you think has VHL or a RET mutation. So just VHL, SDHB, and RET alone, 25%. And then if you add in SDHA, C, and D, and related genes, it's 35%. And so this is really a very, very low hanging fruit yet again. And so anybody with a pheo or paraganglioma, we would screen. Unfortunately, they're not a huge number, so we're not mainstreaming these yet. And then importantly, there are predictive implications. So patients with pheos or paragangliomas that are related to SDH mutations actually have a high response rate to TKIs like sunitinib. And so we do immunohistochemical staining for the SDH proteins. And if they're absent, that will be another reason to initiate germline testing. What about melanomas? So we use 3 or more melanomas. 1 or 2 melanomas are actually quite common, at least in our population, or uveal melanomas. What's really important is age of onset alone is not a criteria. The yield's actually very low. So we will often get referrals. I have, they will send a patient who has a melanoma at 21 or 22, and the yield there on genetic testing is actually very, very low. So CNS, you're thinking of brain tumors with other syndromes that we've already kind of talked about, things like VHL, NF, TSC, but also remember Lynch syndrome and Leishmania. So any of the other cancers that go along with those syndromes, so really quite a few. GI stromal tumors are something that I treat a lot as part of my sarcoma practice. And so any individual who has more than one GI stromal tumor, either synchronous or metachronous, just with syndromic manifestations. So anytime you see a GI stromal tumor with a pheochromocytoma or a paraganglioma together, that is almost always an SDH mutation. That's something called Carney's dyad or triad. And so think just with pheochromocytoma, they need to have genetic testing. And then we stain our GISTs as well for SDH. And so, most GI stromal tumors have a c-KIT mutation, but the ones that don't have c-KIT mutations or platelet-derived growth factor mutations, we call those wild type. They're often driven by other things like SDH mutations. And the ones that are SDH deficient might actually have a hereditary form of GI stromal tumors. So what genes do you test for? Like say somebody's eligible for a breast ovarian panel. Well, that's definitely beyond the scope of the talk today. And if I hadn't put you to sleep already, I would definitely put you to sleep with that part of it. But almost the entire genetics world has moved to these big panels, right? So when I actually started doing genetics before Mohammed came to work with us, we were actually doing single gene testing. And it was incredibly tedious sometimes. So you would start with BRCA, and then if it was negative, you would do P53. And if it was negative, you would move on to the next. And honestly, not jokingly, sometimes by the time you finish testing, the patients had passed away, right? Because it could take years. So panel testing has really totally revolutionized cancer genetics. In our system, we tend to use custom panels because it's a little bit less cost prohibitive to using large commercial panels. And so just to show you kind of like what our panels would look like, if you look at the breast, ovarian, prostate panel, you can see the genes that we would interrogate. And if you look 2 down at the hereditary GI panel, you can see that they're relatively comprehensive and would cover most of the highly penetrant genes, but a lot of the I wanted to very briefly talk about potential germline results in tumor testing. Is that what part of your talk is going to? So this is a complex topic, right? And at some academic centers, they have the luxury of giving you paired germline and tumor, but many do not. And like, for example, we don't usually have paired germline. And so trying to figure out what you actually do germline testing on is quite complex. It should be in consultation with a genetics team. There's some very good guidelines. The one that I like are the ESMO guidelines that came out in 2019. So they're fairly contemporary. And this was germline focused analysis of tumor only sequencing. So the bottom line is that a sizable proportion of pathogenic variants in cancer susceptibility genes that are found in tumor only analysis are of germline origin, but the fraction is highly variable between different genes. And so you have to have a somewhat practical approach, because otherwise you're going to be doing germline testing on every single patient. So usually you're relying on throwing out the ones that have a low variant allele frequency, and those where the possibility that something germline is quite low. So for ESMO, they recommended limiting it to a variant allele frequency of 20 to 30%. You know, in an ideal world where things work perfectly, if you have a germline mutation, the allele frequency should be around 50%, right? But we know it can be considerably lower just by contamination, by amplification of non-mutated areas. It can be higher or lower, so kind of 20 to 30. But if it's 5%, for example, the chance that you're missing a germline mutation is quite low. Not zero, but it's quite low. And then they limited themselves to 27 genes where the predicted positivity rate was greater than 10%. And based on this criteria, based on a sample size of about 12,000 that they analyzed, only 6% required germline analysis. And they missed very, very few germline mutations, like less than 0.2%. And 60% of them were of true germline origin. And so these are the genes that they recommend testing. So if you find something in tumor, these are the ones that they would recommend going on to germline testing for. And so some kind of pragmatic approach like this really is needed. So my conclusions are the introduction of cancer gene panels and advancement of higher throughput genetic testing has made universal testing for germline mutations much more accessible, but we're going to need to use mainstreaming more and more because the genetics world is very under-resourced. And it doesn't seem to matter how many genetic counselors you have or cancer geneticists. You just start to catch up and then you get overwhelmed again. So we've got to throw some of that back into the oncologist field in terms of starting the testing. And then whom to test is certainly evolving quite a bit. And as we continue to relax criteria to pick up more patients who might have actionable mutations, I think we're going to likely end up offering some form of germline testing to most of our patients. And I will stop there. Thank you.
Thank you, Kevin. That was great talking. Now we're going to move on. We'll go back to the schedule with Dr. Saad Khan, who's an assistant professor, who's going to talk from Stanford Hospital and Cancer Institute, California, who's going to talk to us today about genomic and genetics complexity and what oncologists need to know. See you online. I think you're muted. Okay, go ahead.
Yes. Good afternoon, everyone. Assalamu alaikum. I hope you guys can hear and see me. I'm going to share my screen and presentation, and I will be driving the presentation. Let me just make sure this works. All right, so I hope all of you can see my slides, and then we will get started on today's topic. I think that Dr. Zabik touched on many things, that there is increasingly more of an overlap between what used to be important for a geneticist and germline mutation doctor to know about, and now we're starting to see as a practicing medical oncologist. The line between somatic and germline mutations has changed quite significantly. I think that you will see that across the world, even in North America, there are quite a bit of differences between practice patterns. And even within my state, California, there is a wide variety of differences in how this testing is performed for patients, and a lot of debate about what the right answer should be. So unlike clear guidelines that we would all hope that we would be able to provide for our patients, there is a little bit of a wild, wild west, which is apt for where I am. So today's talk, we'll talk about what current next generation practices are. And then we're going to use a case-based example of several items, as Dr. Zabik mentioned. I think if we were going to go into the weeds and be very detailed about it, that would take several hours worth and an entire day's symposium rather than a 20-minute talk. But hopefully we'll touch on two of the more important things. We'll certainly talk about the real-world limitations of next-generation sequencing, and then in my disclosures, I do want to point out that I do consulting work for Foundation Medicine, so please factor that into any of my recommendations or suggestions. So we'll start with the extreme. So I think all of us in this talk have a basic understanding of cancer as a genetic disease, that there is an interplay between the genomic pattern of a patient that has cancer in the DNA, in other nuclear materials such as RNAs, and then finally in the protein. So we're going to assume that everyone knows about this. And then we're going to start with what was a paper that many thoracic oncologists like myself saw about 8 or 9 years ago and were quite shocked by. But nowadays, this is considered pretty standard. So by way of example, this was a 52-year-old patient that had non-small cell lung cancer, and at baseline underwent what would be considered a relatively straightforward or standard test of fluorescence in situ hybridization for ALK, and was found to be FISH positive for ALK. They started on a particular course of treatment with the ALK inhibitor. And then because this patient was being treated at Boston at one of the most advanced cancer centers, they had several sequences of their tumor testing done where DNA analysis by a whole exome and next image sequencing was performed to guide the particular mutation that was identified in the tumor, as well as which particular treatment should be given afterwards. Now, I remember seeing this, 8 or 9 years ago and thinking, wow, that's very extreme that here we have a patient that not only gets one germline or one testing of their genomic tissue, but serial testing. And of course, now I see myself doing this quite regularly, where not only will be performing tissue and liquid testing at baseline, but then several times throughout the patient's treatment course, not just for lung cancer, but also for other cancers where we might think that it has a little less, proven impact is, I guess, the best way to describe it. And I think this shows one extreme. Now, of course, I am fortunate to practice at Stanford, where we don't have that much limitation in terms of cost. And a lot of the patients that come here specifically come here because they want to have a better understanding of their disease. On the other hand, we have to remember that the United States is a very large country with a population of over 300 million people, and not everyone comes to a place like Stanford or Harvard or MGH to get their cancer treatment done. So on the left side of this slide is a recent paper that looked at biomarker testing in the real world. And we'll start with something that, as a thoracic oncologist, I would think was pretty standard and well known for the last 15, maybe even 20 years, which is EGFR testing using traditional protein testing such as immunohistochemistry. And even in the 2010s, the rates of non-small cell lung cancer being tested for EGFR were horrifically low. So these are cancers that were well known, at least in my circles, to have EGFR abnormalities, and yet only 1/5 of these patients were being tested by EGFR. Now, mind you, this is not EGFR testing by DNA next generation sequencing. This is just any sort of test that would determine whether someone has DNA, whether someone has an EGFR abnormality, and then would potentially go on to get erlotinib at that time. Over time, in 2015 or 2016, the number of Americans getting EGFR testing in lung cancer increased to roughly about half. And then in more recent times, it seems that the number is closer to about 60 to 80%. So while you may hear me talk about doing advanced genomic testing, you have to realize that within the real world, even in the United States, there are many people that get what we would consider the most standard cancer testing missed for various reasons. And they never have EGFR testing for lung cancer, which is still quite a shocking development for me. If you go to the right side, this also shows that there are significant inequities in the testing that we would consider as reasonable or something that we would perform for our patients. And what this looks at is the rates of genomic testing for skin cancers, lung cancers, breast cancers, and evaluates them over time and divides them up by racial quantities, by racial the categories, so you can see that they're there. And it starts in 2014, where you can see very few people were getting initial next generation sequencing performed at that time. And then that number has increased over time, so that in 2020, you had maybe about 40 to 50% of people who were getting genomic sequencing performed using an NGS panel within 30 days of their diagnosis. So a baseline genomic assessment, but it is still not universal. So I think that unlike nationalized health services like the previous speaker was discussing in Canada, we really don't have any sort of easy categorization of when to perform these tests and how to perform them. And this is still a field that we're all learning about how to incorporate these extraordinarily powerful tests. And I think one of the biggest challenges that we have is how do we make sure that the patient who is getting treated at Stanford or MGH or MD Anderson is getting the same treatment as someone in a rural farmer community in Kansas or some other place. And clearly, there is a difference in the quality of care that is being delivered. So we'll start with a couple of examples. This is a patient who was in his 50s and was a never smoker who developed with lung adenocarcinoma in 2014. And per my university, I was in Texas at the time, standard of care, I performed immunohistochemistry and FISH testing for EGFR and ALK. They both came back as negative. I said, okay, well, he probably has some other abnormality. And we had to start him on platinum doublet chemotherapy. He had a great response and had a good life for several years until I had him on taxanes. And at that point, he had a significant development of neuropathy. So I put him on a particular clinical trial that included DNA next generation sequencing. And the result came back as I was screening him for the clinical trial. And it said, oh, this patient has an email for ALK fusion. And I said, well, that must be wrong, because clearly my patient was tested for ALK and he did not have it. And so I went back and I talked to my pathology colleague and I said, hey, there's some mistake here. That, you know, this is an ALK negative patient. Why are they calling him as ALK positive? And it turns out that when they re-reviewed the FISH testing, which for those of you who may not know, it is an extraordinarily labor-intensive and highly technical process. When they re-reviewed the FISH testing, they said, well, it was kind of borderline. I hope you guys can hear me. I heard some background noise, but in any case, I'm going to continue. And when I was told that it was borderline, I said, oh, okay, well, I'm going to believe the next generation sequencing panel. And I started the patient on crizotinib, and the patient had a partial response. So I think that was a good example of how you can see differences in the technical aspects of the various testing that needs to be done, specifically for lung cancer, but now broadly applicable. And it shows the difficulty that those of us who are practicing medical oncologists experience. And this is a busy slide precisely because I don't know what the right answer is. And I find that as I give these talks across the world and across the US, we all have sort of the same questions, which is for, let's take an example of lung cancer. In lung cancer, should we be performing hotspot focused testing, or should we be doing full DNA genomic testing, RNA genomic testing, proteomics when it becomes available in the future? I don't know the answer. What I can tell you is that where I've practiced in the United States, it is very standard for us to not use hotspot testing or focused genomic testing, certainly for lung adenocarcinomas. And I think almost everybody is getting full genomic testing of their DNA panel, whatever that means in the setting that you're in. This leads us to the other thing, the other issue that often comes up is that there's a wide variety of commercial testing that can be done, that can be used different panels, and then you have your own internal genomic testing. And that leads to tremendous confusion because curation of these genes is one of the most important things that needs to be done. And understanding what you're testing for is a big deal. As an example, I lead the endocrine cancer research group at Stanford. I treat a lot of thyroid cancer, so I deal with a lot of RET and NTRK abnormalities. And when I came to Stanford, I said, I need to be testing all of my thyroid cancers for RET and NTRK. So I was using a panel called STAMP, which is the abbreviation for what you see here. And it turns out that the genes that I was testing for were not included in STAMP, and I needed to order STAMP fusion. So I only learned that, unfortunately, a year and a half after I had been ordering STAMP and wondering why my patients did not get RET or NTRK abnormalities picked up by that particular in-house genomic panel. So then I started sending both STAMP and STAMP fusion or using a commercial panel. And these are problems that are universal. You see those develop across different locations where everyone has their own in-house panel, and there are multiple benefits to using that versus arguments in favor of using the commercial entities that perform this as well. So the short answer is that here, I think clearly there is a benefit to doing genomic testing, which allows you to pick up greater mutations for your patients. And for me, I have found the greatest benefit to be in lung cancer, although I think that, as you'll see, there may be benefit to doing in other cancers as well. And so now we'll talk about a patient that has a thyroid nodule. The representative picture is on the right here, but this was a patient that was 69 years old and presented with a neck mass that had developed from a neck nodule that had been observed for the previous 5 or 6 years. Previous biopsy attempts had been inconclusive and the mass was observed, but within the previous month, the mass had been rapidly enlarging, the neck was filling out, there were voice changes noted as well as breathing difficulties, and a repeat biopsy this time indicated thyroid cancer with some poorly differentiated areas. The patient presented to my clinic, and at that point, there was a debate about whether this was a differentiated, poorly differentiated, or undifferentiated type of cancer. And you will see in a second that that almost doesn't matter anymore. But as is common practice in my clinic, I put in an order for tissue next-generation sequencing as well as liquid DNA and RNA next-generation sequencing to be performed in this patient. And I said, come back and we'll talk about what the treatments would be. Unfortunately, his tumor did not grant us that opportunity, and he developed severe respiratory distress due to enlargement of this mass, and he was intubated at an outside hospital with a collapsed airway. And because the tumor was extending all the way through, a trach was not possible. So while he was admitted at the outside hospital, his blood tumor or his blood circulating tumor DNA came back positive as BRAF V600E. And so I started him on dabrafenib and trametinib. I called the outside hospital. I said, let's make a slurry, a mixture of these capsules and pills and deliver it through this patient's gastrostomy tube. And while he was intubated, he was getting dabrafenib and trametinib. And 3 days after he started, the mass had shrunk so much that he could be extubated, and he returned to clinic and he feels great. I think the key part here that was unpleasant for me to figure out was that when I saw the result of the NGS on the tissue, it said it was insufficient, that there was insufficient cancer cells for them to be able to successfully perform the test. So if I had not performed the liquid test at the same time that I performed the request for tumor analysis, I would not have been able to identify a BRAF abnormality, and then immunohistochemical staining was not possible because this patient had such poor cellularity, and potentially, there would have been other technical issues with performing it. And so why does this matter? So why should you care about aggressive thyroid cancers? Like medical oncologists in the US, I presume that many of you very rarely see these patients. Well, the reason for that is in the upper right side of this slide, where dabrafenib and trametinib is no longer just limited to melanoma. It is now a problem that is spread across basically any cancer. And in the United States, the FDA has approved the use of dabrafenib and trametinib for essentially any solid tumor that has a BRAF V600E abnormality. And this is by no means a unique situation. So instead of being a thoracic oncologist or a head and neck oncologist, a gynecologic oncologist, sarcoma oncologist, increasingly, all of us are needing to think in terms of the genetic drivers of the mutation. Now, whether they're germline or whether they're somatic, these are things that we need to know about. And this is by no means an exhaustive list, but these are the things that are most obvious and show various drugs that are available for a particular biomarker that is identified in tumor specimen and can be given regardless of whichever tumor type you have. So we heard about microsatellite instability previously. There's a lot of debate about tumor mutation burden high being an indication for the use of pembrolizumab, but this is certainly something that is used for many people in the United States to get pembrolizumab. And then of course you have NTRK, RET, and BRAF V600E. So today, these are referred to as tumor agnostic approvals, and cancer patients who have this associated biomarker of any site have numerous FDA-approved options, let alone the clinical trial options that may be available. And I think you're seeing a shift away from organ-based definitions of cancer towards a cancer that is driven by a molecular mutation and defining treatments. We'll move on to the third case, where, again, we had a 52-year-old gentleman who had a 5-centimeter cervical lymph node, and it had been biopsied and returned as adenocarcinoma of potentially salivary and potentially lung origin. I ordered a PET CT for him, and he had lung nodules that were noted. He had no salivary cancer primary, which is common because many times people can end up with salivary gland tumors that are minor and difficult to identify on PET. So I ordered tissue, DNA next-generation sequencing on him, and that had no actionable results. And RNA NGS at that point came back as NTRK fusion positive. And the patient was started on entrectinib. And to this day, I think you could find people that would make arguments about whether this patient had a salivary gland cancer or a lung cancer. But the bottom line is that it almost doesn't matter. He has an NTRK-driven cancer today. And almost 2 years after I first met him, he has been on entrectinib, and he continues to have a complete response with resolution of his tumor for his NTRK-positive cancer. Now, you'll hear a lot about NTRK. We all have heard a lot about NTRK, and why is this? And this is referred to as a waterfall plot. So at the line 0, which is horizontal in black, this refers to the size of the tumor for patients that have NTRK fusion positive cancers of various subtypes. And the color coding of the bars going downward refers to the various subtypes of the cancer. And you can see, again, not limited to head and neck or sarcoma, but in basically any type of cancer, whether it might be non-small cell lung cancer, pancreatic cholangiocarcinoma, you may see some evidence of activity. And not only do you see evidence of activity, the amount of reduction of the tumor is very dramatic. You can see on the extreme right of this slide that about a third of patients had 100% reduction of their tumor size down to nothing. So if you started with a 10-centimeter tumor, you had nothing remaining by the time you had been treated with this NTRK inhibitor. Of course, on the left side of this slide, there are still patients that don't respond, but the overall response rate was 61% in this study that was reported, and the median duration of response was 20 months. And imagine if you are one of those people who otherwise had an NTRK fusion but could not have been identified. That would be pretty awful to know that these were drugs that are well tolerated and have such a dramatic impact. The philosophical question that comes up in all of these debates is how many patients in your clinic are you willing to test to identify that 1 out of 100, 1 out of 200, 1 out of 500? Those are the numbers that we're looking at for NTRK fusion positive. But if you find that patient, their life is transformed. Unfortunately, you need to test a lot of people to find the NTRK fusion. But if you test nobody, you will never see these results in your clinic. And this slide is from another set of talks that I give for clinical care options educational session, CME, for discussion about where you might want to think about it more. And we divided up into 3 different areas. So one is cancers where the likelihood of finding a TRK fusion is highly uncommon. That's pretty much every common cancer that you'll think of. So lung cancer, pancreatic cancer, cholangiocarcinoma. And on the other hand, in orange, you have uncommon cancers, which are highly driven by NTRK. And that includes salivary cancer, which is described as mammary analog secretory carcinoma, as well as secretory breast cancers, as well as on the right side, some pediatric sarcomas as well. And then there, the prevalence of NTRK fusions is very high, so probably greater than 60 to 80%. And almost certainly, if you were to test for it, you would find it. And then in the middle, you have common cancers, but NTRK fusion is there, but it's not always seen. And that includes thyroid cancer and GIST. And so if you see these patients, you may want to consider testing for TRK if you've run out of other treatment options. Now, we'll talk about the details of what RNA sequencing entails in just a second, but in this patient that we talked about had a DNA NGS that was negative for an RNA NGS that came back as positive. What does that signify? And so what this means is that the genomic material that was analyzed by the DNA did not demonstrate an abnormality, but by the RNA, there was an abnormality that was identified. Now, there are different technical reasons why this may happen. There are different biological reasons why this may happen. And by no means is this an isolated event. We know that DNA gets transcribed into various RNAs that can then be analyzed. And so there are some situations where the DNA analysis tells you that there is no abnormality. And this is what was the case in a paper that came out of Memorial Sloan Kettering, where they used their internal DNA testing. And for patients that had a DNA negative tumor, the one that had no genomic abnormalities, if they did further RNA testing, out of 200 or so patients that were DNA negative, when you tested their RNA, roughly about 15% went on to have new actionable abnormalities identified. So whether they were fusions or mutations or whatever they were, they're listed in the very colorful pie chart in the middle. So there was some ALK, there was NTRK and RET and identified. And then out of those patients that were DNA negative for abnormality, but RNA positive for a particular mutation, if you assigned a drug for that particular abnormality, over 80% of patients went on to develop a clinical benefit from that. And I think that this shows that there is utility in performing RNA. Although again, I say this from a place where we are not constrained by resources, and there still remains debate about how aggressively to use this. And you can see this on the right side, where even in lung cancer, there's a lot of discussion back and forth about whether DNA and RNA testing should be considered standard of care. These are kind of open debates that are taken from the lay literature that anyone can go see. But I think there is certainly a position for people in the United States to say that both DNA and RNA testing are considered standard for pretty much everybody. And certainly for lung cancer. And so just a little bit of detail about what RNA testing would be. Again, this is a sophisticated audience, but I think just so you're aware, again, there is a link between DNA, RNA, and then final conversion into protein. Where we are today is that the majority of our next generation sequencing includes DNA testing, although as you saw on the prior slide, the conversion from DNA to RNA allows you opportunities to identify biology of the tumor that would otherwise not be picked up by sole DNA testing. And the process of RNA testing includes taking RNA from a tumor specimen and then forming fragments of it and then using the reverse transcription process to develop RNA or DNA that can then be analyzed. And the specifics of it are just as big a black box to those of us who are in this field as they are to you, because every commercial lab uses a different process, and much of this is not general knowledge about how they use their process. And the problem is less about the general understanding of how RNA testing is performed, but more about the specifics of the algorithms that are used. And again, this is another area of interest to me, which is the use of RET testing and using RNA to identify specific fusions. Again, in lung cancer, these are uncommon events, but they clearly do happen, and especially with the large number of people that develop lung adenocarcinoma, there are going to be quite a few that have RET fusions that we believe are best picked up by a combination of DNA and RNA NGS. But again, the possibility of doing that for every patient with lung cancer in the world may be a little bit more challenging. So just by way of a quick summary before we wrap up, next generation sequencing allows for testing of multiple alterations simultaneously. RNA next generation sequencing is good at detecting additional gene fusions. Clearly, circulating tumor DNA is an option, but sensitivity can be an issue based on the tumor subtype that you have, and as well as the amount of cancer that you have in your body. And then we already talked about the risks and benefits or advantages and disadvantages of using immunohistochemistry in fish, and certainly in the United States, using RT-PCR is relatively uncommon. And then so to wrap up, we'll just talk about where the field is headed. And in the United States, most of the exciting clinical trials that are coming up do incorporate some degree of next generation sequencing. And we have NCI match, taper, combo match, liquid match. I think these are all things that many of you may have heard of, but by way of summary, the NCI match, which is the schema for the trial here, did DNA next generation sequencing for patients at baseline or at entry into the study. And if they had a particular genomic abnormality, they were paired with a single targeted therapy that was effective or expected to be effective. As it turned out, that using a monotherapy in this setting did not have a dramatic impact as we wanted. And so the next generation of the trial, which is now active in the United States, is referred to as combo match. So it's same basic idea of doing genomic testing, and instead now we proceed with this double or dual blockade of pathways to try to get a better response rate than with monotherapy. And so wrapping up, for you in your clinic today as a practicing oncologist, I thought this was a good starting point, but please note that this was when to order NGS testing in 2020. So even within the last 3 years, I would imagine that this has changed. And so on the extreme left of the slide, you have where the authors suggested that NGS testing was not indicated. So early stage cancer undergoing definitive therapy, a 1 centimeter small hormone positive breast cancer in someone who's 85 years old probably doesn't need NGS, but even there, you could make an argument that there is some benefit towards doing that. And then on the right side, you have someone who has a rapidly progressive cancer with a very poor prognosis, poor performance status. There are occasions where we'll get the NGS testing done after, and that get the results back after the patient has already passed away. But certainly, in the middle, where the least debate in the United States is for advanced non-small cell lung cancer, although you can now make the argument that for adjuvant testing, you need to do a little bit more testing. And then, as we mentioned, some rare cancers such as sarcoma, thyroid cyst, and others where it could be really impactful. And then the additions in 2023 that I put at the bottom are whether you have access to the tumor agnostic agents such as anti-PD-1, NTRK, and BRAF, as well as patient preference, which, for patients that come to Stanford, they are expecting that their tumor is sequenced not just once, but multiple times. So in conclusion, I know that this is a tremendous amount of information that we have to keep up with. As someone who not only is in the field and performing research, and treating patients, it's just impossible for me to keep up with. And so it requires a constant effort on our part, and we all must make the choice to decide to be as up to date on this as we can be. I think one of the common themes that I see when I deliver this talk internationally is say, like, oh, you're from Stanford, you don't have any money problems. Our patients are very different than yours. I did want to point out that, again, the United States is much bigger than Stanford in California, and every clinic and every patient is resource limited. And it is the job of the oncologist, the job of us to find out where we can have the largest impact of these advanced and expensive tests on our patients. And then while a complete triad of access to drugs, clinical trials, and genomic understanding of the tumor is the best option for delivering great results for our patients, we know that across the world and across health systems, we don't all have access to clinical trials and all access to the latest drugs. But the one thing that we do have within our control is understanding the genomic drivers and testing methodologies that are available. And so that is the one thing in our control. And for those of you who are listening and watching this talk, you guys are doing the work, which is understanding some aspects of this. And again, by no means in a 20-minute talk can we cover everything. And so finally, we have, remember, the reports that you would get from the DNA and RNA testing are often have a lot of information on there. So you can even refer to those to try to understand what these mean. But by no means are they the only treatment or only resources available for you. I've seen essentially the equivalent of Twitter tumor boards where oncologists from all over the world are presenting genomic testing. They may have different privacy laws than we do in the United States, but they refer to genomic patterns, and they get guidance from patients, from oncologists all over the world. And I know that we would certainly be more than happy to provide that information to you at Stanford as well. So again, thank you very much to the organizers of this conference, the audience, and all the patients who have participated in this study. And thank you all very much, and I'll be happy to take questions during the Q&A session.
Thank you so much, Dr. Khan. Thank you so much, Dr. Khan. So as the audience noticed that there is a slightly change in the agenda because technical issue that was fixed, we'll back to the same schedule and to our next speaker from Queensland, Australia, and Dr. Maliha Hazar. She will talk about, she's a associated director of Foundation Medicine, and she will talk about how we can understand and the genomic test for oncologists. Dr. Maliha.
Thank you. Good afternoon, everyone, once again, and I apologize for the technical difficulties that we faced. So again, I would like to first of all thank the organizing committee for the opportunity to be with you today and discuss about comprehensive genomic profiling. How can it be integrated into the patient journey, and importantly, how to interpret the results from these genomic profiling. And these are my disclosures. So I'll start with the question of what is the comprehensive genomic profiling, or I will refer as CGP. So CGP definitely provides a deeper and a clearer view of individual patients and their disease. So this is a next generation sequencing approach to detect novel as well as the known variants of 4 main classes of genomic alterations, as well as genomic signatures, not only to provide prognostic, but also to provide diagnostic as well as a predictive insight that inform the research and the treatment decision across all cancer types. So in the era of precision medicine, the genomic profiling has certainly evolved from a diagnostic test where the tumors are tested only for the guideline recommended therapies as well as the biomarkers for immunotherapy, to a more comprehensive genomic profiling where the results can inform not only the guideline therapies, but as well as clinically relevant alterations, biomarkers to help inform immunotherapy, alterations with resistance implications, as well as the pertinent negatives. And this certainly creates a new array of management options for the patients. So at Foundation Medicine, the comprehensive genomic profiling really translates this genomic information into clinically actionable knowledge in the form of a curated quality control report to help physicians to identify targeted treatment options. So this is just a front page summary, this is just a presentation of the summary page of one of our reports, specifically from a melanoma specimen. And all the sections or the information that can be found is listed here. But what I want to highlight is that in our reports, only the reportable variants presented to you are the curated alterations that receive content. And when we said the actionable alterations or the variants that are reportable, this really includes well-characterized biomarkers in cancer, alterations or the alteration classes that is functionally characterized to contribute to tumorigenesis, predicted to be the oncogenic driver, as well as the alterations that are demonstrated to confer resistance to therapy. And this is a summary page from a liquid specimen, and there are some additions that you will find, such as the tumor fraction, which we will discuss in details. And as shown here, the clonal hematopoiesis, as well as the alterations that may have the germline follow-up required, are also listed in our liquid as well as the tissue reports. So I'll start with the importance of the variant allele frequency because at the end of 2021, we started reporting the variant allele frequency for the tissue as well as the liquid, the specimen. So the variant allele frequency that you will see in our reports are the representation of the percentage of the sequence reads that carrying a mutant allele of a patient's cancer. So the caution is really recommended here in interpreting this variant allele frequency to indicate the potential germline or the somatic origin of an alteration, because we need to recognize that this variant allele frequency is impacted by the tumor fraction as well as the tumor ploidy of the samples. So the lower variant allele frequency or the lower percentage of variant allele frequency of one variant versus another is likely speaks to the tumor heterogeneity. So the lower variant allele frequency alterations may be presented only in certain subclones. However, I stress that it is not clear whether a dominant clone is more biologically or clinically important. So, and what we recommend is that the driver alterations detected by the liquid biopsy are actionable regardless of the variant allele frequency or the tumor diffraction. So here on the left, I'm showing you an example of a case where the specimen was tested by the local tissue testing, but none of the EGFR alterations or known alterations to be the driver in the lung was not seen. So later on, the physician sent the specimen to Foundation Medicine for testing. And as you can see here, that we detected EGFR sensitizing mutation L858R at a very low allele frequency, 0.48%. And interestingly, the very same patient was included in a clinical trial, which I'm showing you here on the right. So this is one of the key studies to highlight that the driver alterations detected by the liquid biopsy are actionable regardless of its variant allele frequency. As you appreciate that no correlation between the change in target lesion and the allele frequency of the ctDNA mutation for which a targeted therapy was indicated. In fact, the patient who harbored the L858R clone with a variant allele frequency of less than 1% actually had a complete response when the patient was treated with osimertinib. So there are a couple of important the considerations here. So the targeted treatment response for driver mutations detected by ctDNA may be independent of variant allele frequency. And what we really need to pay attention is the underlying biology, the tumor biology, and the ability to treat the patient with the appropriate targeted therapy options if available. So now I'll move on to the liquid space and start looking at the differences and the utility of liquid versus tissue, because each has advantages and disadvantages. And a common question that we often receive is, when should tissue versus liquid be used as a first option? So this schematic nicely explains when should tissue be considered, and this includes when the tissue is available and has a good quality. And it is also ideal for tumors with a low shed metastatic sites, for example, CNS disease with a local spread. On the other hand, when the tissue specimen is exhausted from the prior testing, or the tissue is not immediately available, low quality, or simply the patient preference is to avoid repeat biopsy, then the recommendation will be to choose liquid biopsy first over the tissue biopsy. So currently, the utility of the CGP using liquid is when the patient progression on therapy. So, however, the message here is that if you choose to use a liquid biopsy due to the reason that we discussed, and if you receive a report which has no actionable alterations, this is nothing to do with the technology, but it's rather to do with the biology. And in a scenario like that, we prefer to reflect on the tissue testing if feasible, because I will touch base on shortly. The sensitivity of the liquid biopsy is certainly dependent on the how much ctDNA is shed from the tumor. So, in addition to all that, a single major advantage of liquid biopsy is the ability to capture the tumor, the heterogeneity. Because as you appreciate that the tumor biopsy is not able to capture the genomic landscape, the overall genomic landscape of the patient's entire tumor burden. So tumor biopsy may not capture the subclonal population of the tumor cells with distinct alteration, as well as the tumor biopsy only from a single lesion will miss alterations unique to the other lesions. So during the patient's the cancer journey, the utility of ctDNA, the NGS, certainly give us the snapshot of the clonal evolution, the clonal competition between the clones that emerge as a result of the selective pressure, and also indicates that the genomic alterations that the subclones the carry, which may help us to tailor a treatment plan, because often these subclonal the variants that we see using the ctDNA is an indicative of the treatment resistance. And here I just want to show an example from one of our very recent study that the Foundation liquid test is able to detect resistant mechanisms. Here on the left, I'm showing you the percentage of the specimens that where the ALK mutations were seen in non-small cell lung cancer following the EGFR targeted therapy. And as you can see, the majority of these patients, when tested with liquid biopsy, we were able to detect these ALK-driven resistance clones. And in the setting of a prostate cancer, again, as we know, the mutations in AR, the estrogen receptor, is a known resistant mechanism to the ADT therapy. And by using the liquid biopsy, we will be able to capture the subclones. And often we do see them at a very low variant allele frequency to be present in these patients where the patients started to show resistance. But there are multiple considerations that I would like to stress today for the use of ctDNA in genomic profiling. So as we all know that the tumor content in blood, the shed by the tumors itself, is less than 1%. In fact, is around 0.1%. And we know that half-time of the fragments is extremely low. Don't know where that slide is. So you need to come up to this slide.
Yes. Same.
So it's very important to understand the differences between the tumor types and how much ctDNA is shedded depends on the tumor itself. So we know that some tumors are considered to be as a good shedders, whereas some tumors are known to be not good shedders at all. And we simply do not know the biology as to why some able to use apoptosis or necrosis as a mechanism to shed more. But it's very important to pay attention the tumor type itself when we are considering liquid biopsy. In addition to that, the second important consideration is the tumor burden. And by that, I mean the tumor, the amount and the location. So we know that the amount of ctDNA is shedded by the tumor increases by the tumor burden. When the tumor is at stage 3 and 4, we know that they are able to excrete more of the content, the DNA content into the bloodstream. And also the timing and the type of last therapy that patient receive will be dictating the sensitivity of the ctDNA, the sequencing. Next slide. Perfect, thank you. So what is the tumor fraction? So this is very important, and I want you to take away from today's talk is that tumor fraction is a key when you are considering liquid biopsy. So the tumor fraction is an estimate of the percentage of the circulating tumor DNA, ctDNA, present in a cell-free DNA sample. So at Foundation Medicine, we use a computational algorithm to predict the tumor fraction. And there are certain characteristics of the elevated tumor fraction and the non-elevated tumor fraction. And I'm going to touch base quite shortly, but the low or non-elevated tumor fraction eventually reduces the sensitivity of our testing, and which eventually leads to the false negative reports. So here on the left, we are looking at a scenario where we see an elevated tumor fraction. So we have, as I mentioned, higher stage tumors, metastatic, patient is progressing on treatment. So all of these factors really contributes to a case where we expected to see elevated tumor fraction. But as I mentioned, the tumor type is also important. The lung, breast, and GI are some of the examples of the good shedders. In a scenario where you receive a test and you see that the tumor fraction was not elevated. So first of all, first thing that I would look in that report is the tumor type. So if it is a glioma patient, if it is a renal cell carcinoma patient, if it is a sarcoma, or even pancreatic tumors, we know that are not good shedders. So it's not surprising to see low levels of tumor fraction being detected in that case. In addition to the tumor type, the lower stage, local or locally advanced scenarios, or even the patient responding well to the treatment is not the right time to collect a liquid biopsy because we won't be able to obtain any material to do the sequencing. This one. And excellent. So in addition to the tumor fraction being important, what we have learned from our own studies that was very recently published again, that the tumor fraction varies across and within the tumor types. So what I want to highlight is that we do not know this magic number as to clinically meaningful tumor fraction. So if you ask me what should be the ideal tumor fraction, I can't really give a the concrete answer. But what we are learning from our own research and others, that when the tumor fraction is greater than 10%, it really increases the sensitivity of the testing, the genomic testing, to be able to identify the genomic the alterations. But what I want to show you with this slide is that, let's say, the colorectal cancer, if you take the colorectal cancer as an example, as you appreciate, the 46% of these patients have tumor fraction is greater than 10%. So which means we can confidently expect the liquid biopsy testing, if follow those criteria that we discussed, to come back as positive, where we see actionable alterations. But if you look at, for example, the thyroid cancer patients, as you can see, only a small percentage of these patients, around 7%, only harbor a tumor fraction greater than 10%. So it's really important to look at the tumor type, but also expect that within a given tumor type, we need to look at all the factors, consider all the factors that we just discussed to make the judgment whether it's a right decision to order liquid biopsy. So next slide. And with this slide, this and next, I want to highlight that the importance of tumor fraction. So elevated tumor fraction not only increases the sensitivity of our test, but also increases our ability to detect some of the complex biomarkers. And as you can see here, the cases of microsatellite instability high, cases with the high blood TMB, to be able to detect gene amplifications, gene deletions, as well as concordance between the gene fusions increases significantly when we have cases with the tumor fraction elevated greater than 10%. And in the next slides, I'm just going to show you very briefly the positive percent agreement, which means when the positive percent agreement is high, it tells us the ability of a test to detect the genomic alterations. as you can see, when the tumor fraction equal and greater than 10%, which are the orange bars here, the positive percent agreement reaches 100% between paired tissue and liquid. Again, highlighting the importance of the tumor fraction, not only for you to be able to see a positive report, but also for us confidently call out the alterations. The next slide. So with the liquid biopsy, in addition to the actionable alterations, we also see different genomes, if you will. So we have the tumor genome. We also be able to detect the germline, the alterations, but as it was noted earlier, since we don't sequence the normal tissue, we cannot confidently call out. We can only predict by looking at the variant allele frequency. But in addition to the germline and the tumor genome, the liquid biopsy inherently also captures the heme genome. And I'm gonna spend a couple of minutes on that. In the next slide, please. So, and I want to specifically talk about the clonal hematopoiesis. So, as you appreciate, all cell-free DNA, including the circulating tumor DNA, is sequenced in a liquid biopsy the specimen. And often we know that the detectable cell-free DNA can also originate from a benign clonal population in the bone marrow. So through a process called clonal hematopoiesis of indeterminate potential, also known as CHIP, these the mutations or these subclones the emerges. And interestingly, these the benign clonal populations often harbor a mutation in genes that we commonly see in hematological diseases. And some of the very frequently seen the CHIP-associated alterations are listed here on the right. The NMT3A, TET2, ASXL1, the JAK2, IDH2 are some of these CHIP-associated alterations. These are very important to, the CHIP is very important to point out because sometimes it is associated with hematological the malignancies. It may indicate increase the heart disease and so on. And interestingly, the prevalence of CHIP increases by age. We know that the patients 70 years and older, the prevalence of the clonal hematopoiesis or CHIP increases by 20%. And these mutations often seen at a lower variant allele frequency in older patients, as I mentioned, and notably some of these genes are potentially targetable. Next slide, please. But the only way for us to confirm whether these mutations, some of which are potentially actionable, are coming from the tumor itself, we need to have a white blood cell sequencing. Because at Foundation Medicine, these mutations won't be filtered out. We don't categorically filter out these alterations. We do make a point of whether there's a potential CHIP is associated with that alteration, but the only way to confirm that that particular mutation is representing the tumor is to do the white blood cell sequencing of the patient. And I just want to show you this, the recent study, which they nicely presented that some of the patients, which are confirmed to have a CHIP, actually harbor an alteration in ATM, alteration in CHEK2, as well as alteration in BRCA2. And actually, as part of the molecular tumor board discussion, I discussed cases where the patient history or the family history does really not make sense for a patient to harbor a BRCA2 alteration. And the physician goes back and confirms whether there is underlying CHIP or not, and it comes back as a CHIP-associated alteration. So it's very important to confirm whether the alterations are coming truly from the tumor itself or secondary to CHIP, because this may certainly mitigate from the false, the positive ctDNA biomarker assessment. So in the next section of my talk, I'm going to talk about the the immunotherapy, the biomarkers, the next slide. So I'm just going to skip through quickly due to interest of time. So I'm just going to touch base on the TMB for the biomarkers related, the immunotherapy biomarkers. And I just want to mention that the tumor mutational burden at Foundation Medicine is a quantitative measure of the total number of genomic alterations per coding area. And this is a proxy for the or it's a surrogate measure of the neoantigen load for the tumor, which indicates whether the tumor microenvironment is hot or cold. And as we know from this Keynote 158 study that the TMB high patients universally now defined as the TMB equal and greater than 10 mutations per the megabase. And as you can see from the results that the many different the tumor types or across the tumor types that are included in this study, TMB equal and greater than 10 confirm overall response regardless of the tumor type. The next slide. But what we are learning is that although we're using this universal cutoff of 10 mutation per megabase is recognized, more recent studies now showing us that even patients less than 10 mutation per megabase actually show a response to immunotherapy. Then this raises the question, should we apply this universal cutoff to every patient, or we should specifically look at the tumor type itself? And the answer is really to consider the TMB, the average TMB within that tumor type, and see what is the percentage rank of a tumor's TMB within that the patient cohort. And here, as I'm showing you on the left, this study by Sam Stein recently reported that when the patient's the tumor's TMB percentile increases, the level of response to the immunotherapy increases accordingly. And as you can see here on the right, that the average or the optimal cutoff for a TMB or high TMB varies significantly by tumor type. So the message is that rather than applying the 10 mutation per megabase across all the patients, we should really look at what the median TMB is for that tumor type and take that as a benchmark. And this is just to the slide to show the next one. Thank you to reiterate that the TMB and the PD-L1 are two independent biomarkers, independent but the complementary the biomarkers, and the studies show that TMB may help inform immunotherapy the decision for patients regardless of PD-L1 status. So I'm going to skip this, and I'll come to quickly about the fusion detection, because we discussed about the fusion detection in the previous talk. Thank you. So as it was discussed, the fusions are certainly considered as the driver alterations in many the tumor types, and they are certainly actionable. And this slide just shows the prevalence of the actionable fusions, which are detectable using the DNA, the sequencing. Next slide. But what I want to really highlight here is that there are certain criteria that we really need to pay attention when we see a rearrangement in our reports. So the rearrange or the fusions, I'm just going to take a step back. So the fusions are a genomic rearrangements where two foreign genes come together and leads to the oncogenic proteins, which in turn activates the downstream signaling pathways. But not every single rearrangement actually leads to a fusion protein. So there are three criteria to consider. The first is within the fusion event, the kinase domain should be intact. So we should have an intact kinase domain is number one. Number two is that we need to look at whether the fusion in frame or not, because only the fusion events or the rearrangements which are in frame will lead to a protein that is correctly expressed. whereas any rearrangement that is out of frame will be out of frame, will not lead to a functional, the oncoprotein. And the number 3 is to consider the fusion partners, because we know that the non-fusions, we know their functional consequences. However, for a fusion rearrangements where the binding partner is novel, and we have no functional consequence of that, the rearrangement, then we need to refer back to the first 2 criteria, where the kinase being intact, or the fusion being in frame for the functional protein to be translated. And in the next section, I'm gonna talk about the HRD, the homologous recombination deficiency. Next slide. So here, yes, we can stay on this. So as we know that when there is a defect, or when there is a double strand, the break in the DNA, or even single strand, the breaks, the homologous recombination repair system will try to fix that, the defect in the genome. But when there is a mutation within the homologous recombination repair genes, this creates an error-prone, the error-prone alternative repair pathways being leading the genomic repair, which leaves the genomic scars on the genome. So I just want to highlight that on the left-hand side. So when there is a mutation in one of these homologous recombination repair, the pathway genes, this may lead to functional deficiency in homologous recombination. And as I said, this will leave large scars in the genome. However, I just want to make sure that make it clear that not every single mutation in the homologous recombination pathway genes would lead to homologous recombination deficiency. So these two are overlapping the biological significance. However, there are some other non-genomical pathways, such as epigenetic regulations, which may eventually lead to underlying homologous recombination deficiency. And the pie chart on the right, just to highlight that the promoter methylation, not only in BRCA1 and BRCA2, but some other the homologous recombination repair genes, as well as the mutations in the Fanconi anemia genes, mutation in CDK12, and sometimes we know that alterations in PTEN or EMSY also potentially leads to underlying homologous recombination deficiency. And as I mentioned, when there is a defect in the homologous recombination, this leaves large scars in the genome, and we are able to look at these genomic segments, also known as LOH, the genomic loss of heterozygosity, and make overall the conclusion of whether the genome is the genome is representing an underlying phenotype of homologous recombination deficiency. The next slide. Here, I just want to also highlight another important factor, which is the zygosity. So here I'm showing you a result from a recent study where we took a pan-cancer analysis of homologous recombination associated alterations. Here specifically, I'm showing you the BRCA1 and BRCA2. And we look at the zygosity status of BRCA1 and BRCA2. So the zygosity means that, or the bioallelic mutation means that the variant present in both the allele. Monoallelic means that the mutation is only present in one of the alleles. And it really has an important clinical implications, especially for genomic mutations or the mutations that we do not know the functional consequence. So the distinguishing the bioallelic from monoallelic can really help us understand whether these mutations are biologically neutral or they functionally, or they leads to functional consequences. And as you can appreciate here, that across all the cancer types, in BRCA1 and BRCA2, only bioallelic alterations was associated with increase the GLOH, loss of heterozygosity. And notably, I'm not showing you here, but this association between the elevated LOH, which is the underlying phenotype of HRD, and the bioallelic status was irrespective of the germline or the somatic status of BRCA1 and BRCA2. In this study, we also look at the mutation status in other homologous recombination associated genes and its relationship with the genomic, the LOH score. So, and again, here we actually split the tumor types into either BRCA-associated or non-BRCA-associated tumors. So the ovarian, breast, the pancreas, and prostate were grouped as the BRCA-associated cancers, and the others are non-BRCA-associated tumors. And again, as you appreciate, across HR-associated genes, only the bioallelic mutations, meaning that mutation is present in both the alleles, would lead to elevated LOH, which in turn suggestive of the underlying the HRD. And interestingly, we also look at the level of association, and we group them, bucket them into strong, weak, or no associated with the LOH. And and as you can see in the next slide. Yeah, yes, thank you. If I draw your attention to no association bucket here on the right, that includes ATM, CHEK2, FANK-A, and BAP1. Regardless of their zygosity status, whether they are bioallelic or monoallelic, there was no association with elevated LOH. Because we do get this question so often, you know, when you see an ATM alteration in the reports, you know, whether this patient will, you know, respond to PARP inhibitors or the platinum therapy, but there is no data to suggest that the alterations in ATM, regardless of its bioallelic or monoallelic, would lead to a strong association with elevated LOH and underlying HRD. And in the next couple of slides, which I'm going to very quickly skip through some of the emerging paradigms. In addition to the liquid comprehensive genomic profiling, ctDNA monitoring can also play an important role in the patient journey. So it can be used to detect molecular residual disease in patients with early stage, to monitor patients with early stage cancer, or to monitor patients with a late stage cancer that are receiving systemic therapy. And in the next slide, this is a very recent data just to highlight that ctDNA actually can be used for treatment response monitoring. So this is from a breast cancer setting. And as you can see from the figure on the left, quantitative response data delivered earlier than the standard imaging time points for that particular patient when ctDNA was monitored longitudinally. And in the next slide, we are all aware of the molecular residual disease and how important it is in colorectal cancer. And the last point that I want to make is the TRM, which is the future, the treatment response monitoring. And this may be specifically useful for patients with the advanced cancer being treated with immune checkpoint inhibitors, because often these patients do not respond and some have severe side effects. Knowing if a patient is not responding may help adjust their treatment plan. And this was my last slide. With that, I'll stop here. Thank you so much for your attention. And,
So thank you very much, Malika, for an extensive review of what us oncologists needs to know. I think there's so many things that we really need to know. So without further ado, I think we'll go through to our last part before the satellite symposia, which is the molecular tumor board. So for the last couple of years, we've been presenting what we have been doing as partnering with Foundation Medicine, which is discussing some of our chemorefractory cases and seeing how performing comprehensive genomic profiling helps with those patients. And I guess I have to announce that luckily I have been able to write this as an abstract and it has been accepted at AACR. So I'll be presenting this hopefully in a few weeks in Florida. So I think for the sake of time, we're going to choose one case, and it's an interesting case that is being treated by my colleague, Dr. Al-Garni, who I'd like to ask to step up to the podium and let us know about this interesting case. Now, this case will actually involve you, Dr. Twergi, because it does involve your specialty as well.
Thank you, Kanan. So we planned for two cases, but I will skip the case number one. We'll move to case number two. So basically, this is a 59-year-old male patient with no significant past medical history. He presented to ER with severe headache. This was last August. He had a CT scan that showed large left parieto-occipital mass with cystic component with vasogenic edema, and the differential diagnosis include GBM versus lymphoma. His MRI confirmed the same finding and also multiple lesions in the left parietal lobe. Due to his presentation with this significant edema, he was taken to OR by the neurosurgeon. They did a debulking of the major component of the high-grade tumor. His pathology showed glioblastoma, IDH wild type, WHO grade 4. He recovered well from his surgery and he received concurrent chemoradiation that was finished end of last December. Then he was started on adjuvant temozolomide and he had 2 cycles. And we had done for him a foundation medicine 1 NGS. So we want to discuss, Dr. Malika, the findings, then we can discuss how we can take it from there.
We need to get slides. Dr. Al-Garni, do you have the slides which shows the genomic alteration, the findings? No? Yeah, they should. Yeah, but they should. Okay, while we are waiting for technical support to come, so I'll just, I'll tell you what we found. So this tumor was found to be microsatellite stable with the TMB score of 2 mutations per megabase. And regarding the genomic the alterations, so what we found in this case was an EGFR point mutation, G598V. We found a frame shift alteration in NF1. There was a deletion fragment in PIK3R1, the copy number loss in CDK and 2A and 2B, and we also found some frame shift alterations in KEAP1, and not surprisingly, a promoter mutation in TERT. So I prepared some nice genomic slides, but I think we just need to wait. But so EGFR mutations in EGFR also very commonly seen in glioma patients, but there are certain differences between non-small cell lung cancer and the glioma. So in non-small cell lung cancer, most of the EGFR mutations are found in the kinase domain, in the intracellular part of the gene, particularly in the kinase domain. Whereas the mutations in glioma is most often found in extracellular
domain of the receptor. And now you're gonna see on your screen a schematic which shows 6 major EGFR mutations that have been identified specifically in glioblastoma. So there are, thank you so much. Yeah, the schematic is on the top left. So there are the point mutations, one of which actually, or the one that's seen in this patient is one of the most commonly found point mutation in EGFR extracellular domain in glioma patients. But if you look at the literature, what we found is that this EGFR variant 3 is the most commonly seen the EGFR variant across glioma patients. And this variant 3 is an in-frame deletion in exon 2 to 7. So there are certain the mechanistic differences between this the variant 3 or variant 2, 4 versus the point mutations in the extracellular domain itself. And really the difference is this point mutations seems to still have some level of affinity to its ligand, whereas this in-frame deletion fragments like the variant 3 totally signals through independently of its ligand. So I will bring this back to your attention again, because this, even though low affinity, this the binding relationship with its ligand really creates an opportunity for a potential treatment option for this patient. So here on the bottom left, I just wanted to highlight, or I annotated with that red arrow, that this particular mutation that found in this patient is the second most common EGFR mutation that's seen in GBM patients. And here on the top right, we have some of the targeted therapy options for EGFR altered or the EGFR variant 3 specifically mutant, the GBMs. So it's either the TKIs or the monoclonal antibodies, vaccine, or the CAR T-cell therapies. Interestingly, in GBM, the first generation TKIs do not seem to show any efficacy. There are some studies here. Are highlighted one of the phase 1, phase 2, the paper there, where the GBM patient with EGFR amplification, as well as the variant 3 deletion, show some efficacy to afatinib. And regarding the third generation EGFR TKI, the osimertinib, there is certainly a data for EGFR amplification and EGFR variant 3 mutant. However, if you look at the literature, there is no data to suggest that none of these TKIs will be effective for a patient with the point mutation in the extracellular domain. So it is unclear. It is unclear whether the second, third, or first generation TKIs will be effective in this patient. But in the if we move to the next slide, actually one more. What I wanted to highlight based on the genomic finding here is that the use of CDK4/6 inhibitors. Because this patient harbors a copy number lost in CDKN2A and 2B. So we know that CDKN2A is a negative regulator of CDK4 and CDK6. So any alteration, loss of function of CDKN2A will lead to upregulation of CDK4, CDK6, which in turn predicts sensitivity to CDK4/6 inhibitors. And interestingly, one of these inhibitors, the abemaciclib, was specifically tested in GBM patients alone or in combination with TMZ. And in this clinical trial called INSIGHT, a phase 2 trial, INSIGHT trial, actually abemaciclib was demonstrated some efficacy in the GBM patient when used with temozolomide. So based on the genomic findings, the use of CDK4/6 inhibitor abemaciclib could be a treatment option for this patient. So if you come back to the previous slide, please, Mohammed.
So as I mentioned earlier regarding the mechanism of this point mutation, which is slightly different than this variant 3 that we well characterize. Interestingly, this point mutation in extracellular domain still shows some affinity to the ligands. And on that note, I wanted to present you this, the paper specifically talks about this antibody drug conjugate, the Dipatax-M. And of course, this won't be available in Saudi Arabia. It's only available in United States for clinical trial. But this particular study specifically show that this antibody drug conjugate shows superior efficacy in patients with the EGFR point mutations as compared to EGFR variant 3 mutant cases. So this is certainly an approach that, hopefully when it is available, will be an option for the patients with the point mutations in extracellular domain of EGFR. But yeah, so based on the genomic findings, so this will be my notes for this case.
So I'm wondering if Dr. Saad is online.
Yes. So if I may, can you hear me well?
Yes.
So I think this shows the very specialized and esoteric nature of the knowledge that is derived from DNA testing, where we think we know how to treat glioblastoma, but then you have what to me was an extraordinarily unique situation where you have this atypical EGFR abnormality, and then you learn all of this from Dr. Malika about what the specific implications preclinically and biologically of that would be.
Do you want to share your slides?
I have no slides, so we're just going to be discussing this. And so the slides that I had prepared when we had the molecular tumor board previously were basically, as a medical oncologist, Dr. El-Gharni or Dr. El-Shamari, like what would you do with that knowledge that you gain? And so I had picked out a few case reports for the effectiveness of osimertinib or the effectiveness of afatinib in EGFR V3 mutated glioblastoma. And those of us who trained in the early 2000s or earlier, we were used to saying only practice evidence-based medicine. You have large phase 3 trials that showed an overall survival benefit. And nowadays, instead of having those large phase 3 trials, we're slicing every cancer into various subtypes that makes application much more challenging. And as Dr. Malika mentioned, there might be a novel agent that would be very effective for this cancer, but it may not be available even at Stanford, let alone in the rest of the world. And so you have to make the best judgment for the patient in clinic who's sitting in front of you. And would that be a combination of afatinib or abemaciclib or palbociclib or some incorporation of osimertinib? And how do you justify that to yourself or to others? Is an N of 1 a single case report somewhere applicable to the patient and something that you feel comfortable with? And I think that that's the part that I struggle with the most as someone who tries to adhere to evidence-based medicine, high quality data that shows overall survival benefit. But then you have this very individual patient for which you will never have a large clinical trial that will guide you. But I think here there was a good result. And I also want to congratulate Dr. Ghanan about his abstract being accepted. And unfortunately, I won't be in Orlando this time, but I think there's some more detail to hear about the case that I think show positive results when you do things that we would consider non-standard.
So thank you. So I guess the final question I actually want to ask Dr. El-Gharni, and I also want to ask Dr. Twerki. This was a complex NGS profile. A patient with GBM who had chemoradiotherapy, he's on temozolomide. His NGS showed an EGFR G598V mutation, NF1 and PIK3R1 mutations. Dr. Malika explained the NGS report. I'm actually interested to know, Mohammed, what will you do? What's next planned for this patient?
Thank you, Kanan. So you know the natural history of GBM, it's a matter of time before this patient is going to recur again. Now we have some standard of care in the second line, which including the irinotecan and Avastin. However, given this information that I have, I would consider osimertinib plus bevacizumab, and also I would consider as well abemaciclib. So both agents are available in our hospital, and I think what would determine whether I would use them or not is how is the patient functional status at that time. But I think it's something to be considered.
Dr. Twergi. So we're interested to know, so Dr. Twergi, he's an expert in our CNS malignancies. He's also a thoracic and breast oncologist.
Thank you so much. I don't think I will accept the diploma because it's quite difficult to use the options. It's quite difficult. I know there was not much kind of advances. It has to be normal. Standard care is really concurrent radiation. Pembrolizumab is the last one that has been approved 2005. These options we have in recurrent glioma. Discussed that there are many trials with a number of targeted agents, and all of them really did not turn out to be quite effective. In fact, we haven't had any approval for any targeted therapy. The only exception is probably the enzyme therapy, which is also has been approved in regards to the global and so I know many times we will come across those really I'm not sure we have to act on them or because many of those data are small data. I don't think the data have led to approval of those agents. We're not sure if they are applicable, adaptable. Plus the fact also those there are always resistance to use drug that might is kind of
an off-label.
For such scenario, that maybe I would consider it, but still I would be reluctant to use it since this is not really a good indication. Most of the drivers that has been looked at are mostly linked to histology, whether that is all histology, the only exception of the fact that what's good work for EGFR longer, good work for EGFR low, and has been outlined as probably everything and extracellular, all the different. So I'm not sure I would be confident to extrapolate this. So I may not really open it, but I might still go in the standard care. Patient bed and the options are well, then maybe I will think of this. However, I have to take agreement, discuss it with the patient and join the patient. Also, from a resource utilization, this also has been discussed within the department, within because all of those factors have been approved for different cases. Also, we have to be quite wise to utilize the resources in the fact that the ability of data and such individual.
Thank you very much, Dr. Twergi. So I think by this we'll end the live molecular tumor board. Thank you, Dr. Khan. Thank you, Dr. Malika. And we'll move on to the last part of today's sessions, which is the satellite symposia, which is sponsored by Roche, where I'm delighted to present Dr. Twergi, who is an expert in CNS, thoracic, and breast oncology. He practices his oncology at King Fahd Medical City, and he's going to talk to us about the evolving role of ROS1 in NTRK patients' outcomes with Roseltic.
Slide is blue, always blue. Okay, thank you so much, Dr. Kanaan, for nice introduction. So thanks really, Roche, for supporting this lecture. So I will try to outline the updated data when it comes to the use of entrectinib for NTRK and the ROS1. Mostly the data that I will be going through is in the lung cancer, and probably lung cancer is one of, I would say, the best example for precision medicine, because we have to move in this disease in particular from a single approach, histology, then in a more kind of molecular driven approach, and now we have also PDL1 pathway. We were able to treat almost half of those patients with druggable target that are FDA approved agent, and so we were able to avoid chemotherapy in almost half of those patients with already an FDA approved agent, and many of them, as you can see here, is a quite smaller proportion, especially when it comes to a ROS1, as well NTRK in 1 to 2%. The only exception probably the EGFR and ALK and selected KRAS subtypes. But half of those non-small cell, non-squamous can be go with just TKI. And however, we have to highlight that there is always challenges, especially when doing biomarkers in a real life setting, since there is always barriers. One of them is probably the tissue when it comes to lung, where we are dealing with a small tissue. The turnaround time in a real life is not really the way we have it in a clinical trials. It's not just 2 weeks, it's much longer than that, and probably a month, probably longer than that. There's many logistics that can impact on that. The turnaround time, the reflex testing, the sponsorship, though, this is quite real life scenarios. And this is have seen not within kind of regional level, but also in a more kind of, this is probably US data where you can see that the NGS is being only done in almost, I would say 30 to 40% of those patients. So though the NGS has been a standard of care, it's been also NCCN recommended in most of those situations. However, even though for a common or not a common, the drivers that we know for almost a decade, the best example is the ROS1, which is already we have an agent that has been approved for almost 10 years. Still, despite that, only 60 to 70% has been tested. And if you look at those facts, you will think that probably half of those patients who are supposed to have a driver mutation, we are not really treating them with the right approach. And that's really quite concerning when it look, because we may lose those patients when they get treated in a second or third line. One of the things that also help to impact such challenges is the liquid biopsy, which was already highlighted earlier by Dr. Malika, is you can do liquid biopsy if you have an issue with the tissue, but also it can help you as a complementary approach where you might also increase the biomarker detection. Not only that, but also sometimes, especially in a situation where you have a driver mutations and you need to look for any sort of acquired resistance, you need to track for the resistance. You cannot do biopsy all the time. So definitely you need to have more kind of less invasive way of doing it. And probably the liquid biopsy is the way to go. And probably there is future applications. We have seen some data with regard to liquid biopsy for adjuvant setting, where you might try to enrich those patients who might benefit the more from adjuvant, and also there is a future application for doing this as a screening. Foundation was one of the best modality where you have to look at many genes and the way things get reported, the DNA, RNA sequencing, and that has been outlined earlier by Dr. Malika. The NTRK fusion is not common. It's probably less than 1% of all lung cancer. especially the non-squamous. We already have 2 agents that has been approved for this indication. We have entrectinib and we have larotrectinib. Both has been approved as a first line in non-small cell lung cancer, unlike other histology where might be other options. You might have to consider them in the first line. The data for NTRK is not just limited to lung cancer, but it's included all different sort of tumors that are present in adult or children. It's quite common in a rare tumors histology, especially the pediatric and some other rare tumors that we might see with salivary and secreted breast cancer, and sometimes something in between like thyroid. But if you look at the common disease, it's quite rare. However, probably 1 or less than 0.5 or 0.3, as in this data, you might find those fusions. But since it's uncommon in a common disease, the prevalence of such fusions, you will find it mostly in the common disease, because those are the common disease like lung cancer, breast sarcoma, and others that has been listed. Foundation is quite sensitive for finding the NTRK, and this has been shown in a number of data simply because it's looking at the way of sequencing with the DNA, RNA, and that has been also highlighted earlier. The data for entrectinib has been brought up from 3 clinical trials that are mostly phase 1 and 2 clinical trials. That has been the updated data that we have last year. And if you look at this trial, you can see that almost 150 patients that has been included in this trial. All of them are NTRK fusion positive tumors, different sort of tumors, not just lung cancer, and all of them have received entrectinib and the follow-up. The data cutoff was in August 2021. What's really the message that we have from those combined analysis that including different tumor histology, almost 17 different histology. This is probably the longer follow-up that we have for this analysis. First, those drugs really work very, very well. The response rate is exceeding 60%. There are also complete responder when it comes to patient with measurable disease. The other thing, this is really remarkable because those agents are quite active when it comes to CNS activity, and you can see that also the response rate in the intracranial response rate is also exceeding 60%, and we also have seen a complete responder with this. This is probably the data that has been looked at all sorts of tumors, and you can see the survival is 37 months, and it's quite different maybe from different histology, but this is an overall, the response rate also seem quite durable, and even those with the brain mets, they have also done quite well. What's really important to look at, especially with combined analysis for a different sort of tumors, is to look at the safety, because here we have a larger patient population that almost exceeding 200 that have entered in a safety analysis. The bottom line from this data that most of the side effects are more kind of a grade 1 or grade 2. However, there are some side effects that might be an issue, like weight gain, which is mostly related to the peripheral edema, and those are the grade 3 or more toxicity. There are also dizziness, diarrhea, though those side effects has really impacted in the dose interruption as well as dose reduction. But when it comes to treatment discontinuation, is quite low, probably less than 10% of those. One of the common side effects is dyschezia, which is quite the issue with the taste, and that's quite common, but it's probably grade 1 and 2, but it's really annoying for many patients, of course. The subgroup of patients who has been treated with entrectinib in this analysis for lung cancer, around 22. And that was the updated data that we have at last ELCC in a poster session. You can see that there were 22 patients that have been included in this analysis. The response rate is matching with the response rate that has been seen also with the combined analysis. Most of those are adenocarcinoma. Brain mets was quite common in almost 50% of those patients. The response rate is exactly the response rate that we have seen with other histology exceeding 60%. And you can see also a complete responder on the extreme right at the waterfall plot. The same thing also you can see with complete responder around 10 to 15%. They are complete responder as well. It's quite active when it comes to the CNS, and you can see there's the intracranial response is also quite high in a 50 to 60%. The duration of response also has been shown. It's quite durable. Whether patient has brain mets or all patient, you can see the duration of response is exceeding 19 to a 29-month PFS in a range of 13 to 14 months, and the survival has not been reached for those small cohort of patients. So, intracranial activity was really remarkable with those generation TKI, and it's really exceeding 55% in those patients, as you can see. So, from a safety-wise, I think we have seen same safety that has been seen with the large cohort, that majority are kind of a grade 1, 2 toxicity. Dysgeusia is the commonest. However, when you look at the grade 3, you find more kind of diarrhea, edema, and probably that's might lead to treatment interruption, but the discontinuation rate is quite low. And there was no reported grade 5 adverse event with this small cohort. So for this updated analysis, longer follow-up, entrectinib have shown deeper and durable response for the intrac fusion non-small cell lung cancer, including those with the brain mets, and plus the fact that also this drug have more kind of robust intracranial activity. The toxicity is matching with the earlier reported toxicity for entrectinib. Still, when you look at the NCCN guideline, also you can see that both agents are the preferred option in a first-line setting for non-small cell lung carcinoma, larotrectinib as well as the entrectinib as a first line. Moving to ROS1, that's also is less common, but it's commoner than intrac for non-small cell lung cancer. And we know this subtype, the standard of care has been there for almost a decade now. Things started with crizotinib, and now we have entrectinib as an option for the first line setting for advanced non-small cell lung carcinoma with ROS1 mutation. There are a number of clinical trials looking at this smaller subtypes. The story started with crizotinib, then entrectinib. There are also many other newer generation that also has been looked at. But what's really important to highlight here is crizotinib was and entrectinib are both the preferred indication in the first line setting. However, when you look at the entrectinib, you can see larger patient that has been included in those clinical trials that have addressed entrectinib, plus the fact that also entrectinib has more kind of intracranial activity that are not really seen much with crizotinib for such disease setting. The data that have looked at the ROS1 among those trials has been updated recently at the WCLC meeting, and here are the patients that were included, around 172 patients overall. Almost 67 of them have been received this in a more kind of first line setting. Majority are patient with never smoker, prior line of therapy, and definitely also almost 30 or 40% of them, they already have brain mets. The result also matching with other trials that have looked at the entrectinib. For ROS1, you can see the response rate is exceeding 60 to 70%, including those patients with brain mets, where the response also around 60%. There are also complete responder, and you can see them in the waterfall plot where there are patients who have complete response from this treatment. The duration of responses seem to be durable. I see it longer than the number that we have seen with Interact as an example, but it's in 20-month duration of response. We have longer follow-up for this data, and you can see that the BFS is 16, but when you look at the survival for those patients who has been treated, either overall patient population or those who have received in the first line, the survival is ranging between 44 to 47 months, and that's probably around 4 years kind of duration. This is kind of median survival for a ROS1 positive non-small cell lung carcinoma who are metastatic. And those are not the survival that we do see with chemotherapy, as an example, and even selected patients with immuno. So this drug also have shown the similar kind of trend when it comes to intracranial activity. There was some kind of quite significant response rate that has been seen from intracranial point of view, 40 to 60% response. The duration response also durable, and that's really matching with the other trials. The side effect is almost similar to the side effect that we know for entrectinib. Weight gain is the main issue with this drug, and really this is related to the edema, and sometimes difficult to treat. But dizziness also is one of the one of the side effects that also happen, diarrhea, and you need to be cautious with those side effects and try to work on that. Those side effects might impact on the interruption, discontinuation, and it might help with the dose adjustment, but very few might have to undergo dose discontinuation. So entrectinib is also an important option in a first-line setting for a ROS1, and it showed both overall and as well as intracranial activity with manageable side effect when it comes to ROS1 fusion non-small cell lung cancer. And this still is also the preferred option as well, together with crizotinib for a first-line setting for a non-small cell lung carcinoma with ROS1 mutation. With this, I think I have reached to my last slide, and definitely I would say all lung cancer need to be screened, because this is one of the kind of a standard of care way approach in managing those patients with those. It might be difficult, especially for the Interact, because you need to look for which really histology and when to look for that. But lung cancer has been standard of care to do in GS because we have many options. However, one of the challenge that we might across is, yes, there is a challenge with the testing, but also there is a challenge to find the drug if you know the results are positive. One of the challenge that you find the drug and to be available to your patient, and that's also another challenge that we have to keep in mind. With this, I think it is to the last slide. Thank you so much. Thank you very much. Which is we have that when you choose one.
Yeah, that's a good question. First, we have to understand that I don't think we have data that comparing both. Definitely you need to look at different drug as different entity. When it comes to the efficacy, we have seen the efficacy is almost matching with either with response rate as well as the intracranial response that has been seen. There are side effect difference between both drugs, and that's, if you want to make a decision, you can also work on those side effect difference, plus the fact that not all of the drug can be available at your institution. So
the drug that also available, that's also something that you need to keep it in consideration when you choose and select one of them.
So thank you very much. And I'd like to thank all the virtual attendees, all the 1,000 virtual attendees that have attended throughout this long and scientific day. So by that, will actually conclude this day one of the Precision Oncology Conference. There is a workshop that is sponsored by Roche that will be led by Dr. Malika Hazard-Ratnam. This will be, however, for physical attendees in here. So thank you all for listening, and I thank all the speakers and moderators, and we will see you tomorrow. We're going to start at 9 a.m. Thank you very much. Want me to end here? So I think we'll get a 10-minute
السلام عليكم. Assalamu alaikum. Thank you all for attending this long scientific meeting. We hope that you enjoyed the meeting and you also got some information or informative time here within these informative sessions. Would like to remind you that tomorrow we will be starting at 9 a.m. We'll be starting tomorrow 9 a.m. and we'll be happy to see you also. And please be informed that to get your own CME, you have to attend the 2 full days and to fill the evaluation form, which you will be receiving from Al Faisal University, in order to get your accredited CMEs. السلام عليكم. نتمنى لكم أوقات ممتعة ووقت مفيد مليء بالعلم. نود تذكيركم أن المحاضرة غدا ستبدأ الساعة 8 صباحا، والحصول على الساعات المعتمدة، ساعات التعليم المعتمدة. يجب عليكم الحضور لمدة اليومين متتاليين. شكرا لكم والسلام عليكم ورحمة الله.